Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, good morning and best wishes for all of us.
We would like to thank Vice Rector for Partnership, Innovation, Entrepreneurship, and Business of Universitas Hasanuddin, Professor Dr. Engineering Adi Maulana, for visiting our conference this morning. We also want to thank all invited speakers and all of the participants who had joined us this morning. We do apologize because we start our conference a little bit late on this morning. Welcome back to the second International Conference on Pharmaceutical, Material, Engineering, and Applied Science 2022.
Today, we will have 6 invited speakers who will share and presenting interesting topic. For the first 3 invited speakers, will be guided by Apotheker Andi Afandi, Master of Science. To Apotheker Andi Afandi, we welcome you to the stage. So, Apotheker Andi from Hasanuddin University gained his bachelor on the pharmacy, and for the master program he gained in the University of Hasanuddin, and for the master program he gained it in the University of Newcastle at the year of 2015.
Thank you, Diki and Cindy. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Today, I'll be chairing the first session of this conference. And we have 3 distinguished speakers for this session. So, I'd like to invite Dr. Lutz Vogel from Germany to join with me on the stage. Before we start Dr. Lutz Vogel's talk, I'd like to give a brief introduction about Dr. Lutz Vogel. He's now some education and trainings and political roles, if you can say that. He got degree from universities, study in chemistry and pharmacy, some internship, doctoral degree in 1987, and he got clinical pharmacy certification in 1988, and clinical pharmacist for homeopathy and naturopathy in 2005. All right, I think it's enough. I would like to let you start your speak. Time is yours, sir.
Okay. So, good morning to everyone. Selamat pagi. Yes, you saw here education and training, but which is not shown. I worked for 25 years in a hospital pharmacy, and I was chief of this hospital pharmacy. I started nearly 40 years ago in hospital pharmacy, and now I'm retired. I'm here on behalf of the Senior Expert Service. There are 12,000 senior experts in Germany, and like Hasanuddin University, someone can ask for a senior expert to give him some way of assistance. And that's why I am for 4 weeks with the University of Hasanuddin at the Faculty of Pharmacy. Well, my topic being clinical pharmacy. And when I started working in hospital pharmacy nearly 40 years ago, a hospital pharmacy more or less was a storage room in the basement, giving out drugs to the ward. And still today in Germany, the dispensing of drugs in the hospital is not done by pharmacists, it's done by nurses only. In addition to that, pharmacies at that time in hospital had a production unit. We produced amino acid solutions, for example, given intravenously. And this type of production has completely changed now. It is given up. And for the time being, nearly every hospital pharmacy is doing cytotoxics preparation given out to the wards. But only giving drugs, only supplying drugs is not enough for us as being a clinical pharmacist. No, something had to change. It started as early as maybe 1970 in the US. So next slide, please. Yes, one back. Yes, that's it. So you see 1968, the notion of clinical pharmacy more or less started as a change in perspective that the teaching of pharmacy should change to a patient-oriented attitude. That means, in addition to the classical pharmacy things you have to learn, you should also be trained in acting as a team member in a collaborative way, and soft skills were being introduced in the teaching curriculum of pharmacy in the US. So next slide, please. And this is a European definition from 1983, a clinical pharmacist being a healthcare provider. And we are talking still about safe and rational use of drugs for the individual and for society, but we are still talking about drugs, not now on the patient. Yes, we have a focus on patient or society, aiming for the best possible use of drugs. Yes, I have to correct myself. We talk about the patient, but not yet on patient outcome. We will do next. Okay, next slide, please. Yes. So here, there's the goal, the optimization of drug use. That is really a shift in perspective. You not only talk about applying drugs, administering drugs in a safe way. Now the goal is the best possible outcome for the patient. Yes. And I translated this from the German definition. And the best practice of handling drugs, this is what we are aiming for. So next slide, please. Well, in 1990, another concept was formulated, so-called pharmaceutical care. And indeed, the outcome of the patient was, again, the target of the pharmacist's doing. That means we are aiming for cure of disease, elimination and reduction of patient symptomology. We are aiming for the best possible benefit of drug therapy for the patient. That's was the goal of pharmaceutical care. Next slide, please. Yes, so there come three words which, in my opinion, are the essential core of the clinical pharmacist working in a hospital. You have to design, you have to implement, and you have to monitor drug therapy. If either of these tasks fail, the therapy might fail, and the patient will have not the best possible outcome that we are aiming for. Yes. And this in turn involves three major functions, and these are three functions because number 3 is wrong here. Identifying potential actual drug-related problems, resolving actual drug-related problems, and preventing actual drug-related problems. And Heffler also stated, next slide please, yes, that these fundamental goals are existing for all pharmacists, whether they work in community pharmacies or whether they work in hospital pharmacies. Yes, they are valid. Okay, now we come to something, the so-called FIP, Fédération Internationale Pharmaceutique, formulated in 2008 as a statement for hospital pharmacy. The overarching goal of hospital pharmacists is to optimize patient outcomes through the judicious, safe, efficacious, appropriate, and cost-effective use of medicines. And other statements set the 5 rights. The right patient, right medicine, right dose, right route, and right time. Well, the FIP statements of 2008, they wanted the best possible supply of medication. But maybe you remember the day before yesterday in the workshop, if you participated, there are not 5 rights now, there are 7 rights. And also the first statement of FIP changed completely. The overarching goal now is still to optimize patient outcomes, but through collaborative, interprofessional, responsible use of medicines and medical devices. And the 7 rights have been now, how would you say, information and documentation is added. So you have to make sure that the patient gets the right information, and you have to make sure that it is documented in the proper way. Yes? And we will come to some examples where that failed. And very important, the clinical pharmacist is part of the therapeutic team in the hospital. Okay, next slide, please. When we come to clinical pharmacy, of course, it's more than just the doing of a hospital pharmacist in the hospital. Yes. Clinical pharmacy also means doing research, which enables the clinical pharmacist doing things. And clinical pharmacy identifies and addresses the needs of individual patients or society. So the research in clinical pharmacy is not only resolving individual patients' problems, but it's also looking on public health matters. It ensures best practice in supplying and administering medication and provides scientifically based procedures, best practice procedures. And it improves efficacy in using drugs by doing research. So clinical pharmacy is more than hospital pharmacy, is more than just the doing of the hospital pharmacist. Next slide, please. Okay, and the main distinction between the classical pharmacy curriculum and the clinical pharmacy curriculum is that the classic pharmaceutical curriculum is drug-oriented, yes? So if you're doing this properly, pharmaceutical chemistry, pharmaceutical technology, biology, pharmacology, drug-oriented, I can ask you and you list me all the possible side effects, all the properties of a given drug. But applying this knowledge to the clinical situation of the patient, this is the task of the hospital pharmacist of nowadays. So, and this we have clinical pharmacy, and we have this pharmaceutical care, and this is patient-oriented. Well, that's the main focus on this. Now I will next slide, please. Yes, I would like to show you 3 examples of cases where, which are, in my opinion, suitable for illustrating the need of a clinical pharmacist. So next slide, please. Oh, yes. So this is one patient. He had lung cancer, and despite being diagnosed with lung cancer, he still didn't stop smoking, and he smoked 20 cigarettes a day. And then he got erlotinib, Tarceva is a trade name, brand name, and of course, with erlotinib, the progress of tumor should stop. But it didn't was the case. The tumor progressed. What had happened? Yes, what had happened? That what we know, he had been previously treated for urinary tract infection with ciprofloxacin. So next slide, please. Yes, and then this is what the clinical pharmacist should research for. Cigarette smoking with this patient makes it necessary that the erlotinib dosage is doubled to 300 milligrams a day. Otherwise, it will not function, because cigarette smoking has an effect on the enzymes which are responsible for the metabolism of this drug. Next slide, please. Okay, and then the patient showed during his treatment with urinary tract infection side effects which are typical for erlotinib. And because of his therapy, he reduced his smoking, so the erlotinib concentration went up, and the doctors decided to halve the dose from 300 milligrams to 150 milligrams. Next slide, please. And when you check it in the internet, for example, then you will see ciprofloxacin, which was used for the treatment of the urinary tract infection, and erlotinib. When they are given together, you have to reduce the erlotinib dosage. Yes. And the thing what happened while this unlucky patient was being again admitted to the hospital because of tumor progression, because no one ever told him that when he goes out of the hospital, urinary tract infection being cured, and he gets up with smoking again, he should get up his dose of erlotinib again up to 300 milligrams, and then the tumor progressed. And this should not happen if there would be a proper consulting with a clinical pharmacist for designing, implementing, and monitoring the drug therapy. That should not happen. And of course, it costs more money than the patient is sick now with tumor, instead of giving him the right information that he should use 300 milligrams of erlotinib again. Okay, now the next case, please. Well, we have a 69-year-old male, and he has a mechanical heart valve. Yes, this is what we know. And he was admitted to hospital because of a minor stroke. So, what did go wrong? INR was much too low, 1.4 as a result. And he has a lot of medication, as we will see on the next slide, please. Yeah. So he gets all of this. And this is fenprocommune. Fenprocommune is used instead of warfarin in Germany. So please, instead of fenprocommune, think warfarin, okay? It's basically the same thing. And with this patient, you should aim for an INR from 2.5 to 3.5. Okay, next slide, please. Yes, so you can check all the lists. This is what a clinical pharmacist would do, which was not done in this case, of course. But you will see there's nothing much. And if something like rosuvastatin is taken every day, and then the dose of warfarin will be adjusted to cope with it. So it's not a real problem. So what had been the problem? Next slide, please. Yes, the mechanical valve in the heart was infected by Staphylococcus aureus, and of course he was treated with rifampin. Rifampin and also gentamicin, oxacillin, and so on. Yes. Okay, and that's the solution. You see here, the rifampin therapy, it stopped, yes? And this is a different patient, by the way, and this one is getting warfarin. And the effect of holding down warfarin concentration is still present, even after the rifampin was not given any longer, yes? So you should not only look out for drugs which are actually on the list of the patient, but what have been in patient history, what happens there. Okay. And again, design of drug therapy was missing completely, and the monitoring was missed completely, but this patient, he should have been monitored for INR at least on a daily basis, and even maybe 2 weeks after the ending of the rifampin therapy. Okay, so one more case. Well, that is the summing up of this. So this is a psychiatric patient, And clozapine is a neuroleptic which is very useful to control psychotic symptoms. Yes. And in this case, we don't have problems with white blood cells with clozapine. We have a very different problem. And he was admitted to hospital because psychosis was not controlled, so the patients get very, very agitated. So something had to be done, yes. So again, the patient is actively smoking. Clozapine dose had been raised to 400 milligrams per day, not a problem here. Why they added and replaced chlorprotixane by mirtazapine is still, I don't know. I don't know. Lorazepam is being the drug of choice to do the sedation properly. By the way, only use lorazepam by demand only. You can get very dependent on this drug. But with a clinical pharmacist consulting, never, and I say never, would you have fluvoxamine for this patient? You would have not done it. Well, the patient develops severe pneumonia and is going to the hospital for antibiotic treatment. So next slide, please. And this we see here, fluvoxamine in clozapine. It's a serious interaction, and you have to use an alternative. Okay, next slide, please. And this was happened. He entered the hospital day 1. Then the clozapine dose was raised, not sufficiently, as we see here. Then he went to hospital for this antibiotic treatment, and out of a sudden, the clozapine dose was more than 10-fold higher than previously. Yes? And next slide, please. Well, smoking accelerates clozapine metabolism, which means when a patient suddenly stops smoking, yes, the clozapine dose will rise. More effect of this. Systemic infection also leads to a higher clozapine level, but the main thing is the fluvoxamine. It may indeed lead to a clozapine level which is more than 7 or 8-fold higher than before. Yes. And that's why this patient got into a very high clozapine level. Next slide, please. Okay, we are finished. That's nice. And this is the point. Also, the monitoring did fail. With this patient, a clinical pharmacist would have advised to do the monitoring of the drug at least on a daily basis. Okay, and this is why I'm advocating the hospital pharmacist should always be consulted in a hospital when there are problematic patients. And indeed, all these 3 patients did really cost the hospital a lot of money, which could have been, which would have been not necessary if a pharmacist would have been consulted in a proper way. Okay, and that should be done for the moment. Thank you very much for listening. Sari Makasi.
Thank you very much, Dr. Lutz Vogel. It's really nice and interesting talk. It's really interesting and challenging, I think, for the colleague who work in a hospital, because this kind of study and explanation about clinical pharmacy is really important for us to serve patient and society. And I write some outlines here. He started the talk with a long journey of clinical pharmacy development. It started from, I think, 1968, right?
In 1968.
Yes, yeah, the
in
development
1968.
of clinical pharmacy, and then it's getting better and better. And he also gave some interesting study cases. I think 5 or 4 study cases, and because I am a pharmaceutical chemistry analyst, and I found it's really interesting to understand how clinical pharmacists work in hospital, because we have to understand the drug interaction and also have to consider the lifestyle of patient. All right. We have 15 minutes or 10 or 15 minutes time to Q&A session. We welcome for the attendees to give 1 or 2 questions. All right, please.
Maybe she could also
Yeah,
speak in
you can deliver your question in Bahasa or English. I will
Okay.
help you if it's in Bahasa.
Thank you for. So I want to ask about the interaction of metabolizer. Some human have poor metabolizer and ultra metabolizer. I think bagaimana kalau misalnya seseorang itu memiliki metabolisme yang berbeda. So bagaimana ketika dia menerima obat dan interaksinya yang terjadi ketika dia itu menerima obat ketika memiliki poor metabolizer.
Metabolism?
Iya.
Metabolisme apa? Sorry.
Metabolisme yang rendah, poor metabolism sampai ultra metabolism. Bagaimana interaksi yang terjadi ketika orang tersebut memiliki metabolisme yang berbeda-beda?
Okay. Thank you.
Terima kasih.
Yeah. Sometimes human have like good quality metabolism, like high metabolism and poor metabolism, and sometimes it probably affect the metabolism of drug as well, and have you find or how to deal with that condition, because sometimes it's the level of metabolism is different.
Okay. Yes. Well, in the hospital I did work with, we did no testing on poor metabolizers or fast metabolizers. Yes. We just tried the drug, and maybe, for example, with clopidogrel, there are fast metabolizers and the clopidogrel won't work, then we would have to switch the drug. But we are not testing it in our hospital on a regular basis. Maybe Burkhard can comment on it because he is doing pharmacology research.
Ya, jadi sepertinya akan ada monitor di situ, akan ada dites secara reguler sepertinya. Jadi untuk melihat bagaimana level dari metabolismenya terhadap obat tersebut kalau ada drug interaksi. And mungkin Prof. Burkhard?
Well, Burkhard, in our hospital we don't do testing on poor metabolizers or fast metabolizers, but I think it may be done in pharmacology research.
Yeah.
Not really.
Oh, so di rumah sakit beliau, mereka tidak melakukan adjustment atau penelitian terhadap seperti itu, dan menurut Prof. Bakar itu expensive, ya, mahal, dan ya seperti itu.
Okay.
Alright. Yes.
I think it's okay. No?
Yeah, yeah.
Okay.
Thank you. Thank you.
Yes.
Is there any more questions? Yes.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, Dr. Vogel. My name is Ahmad Ardiansyah. I will ask about the collaboration. How about collaboration in pharmacies and doctor in Germany? About the interaction in Indonesia, pharmacists just say recommendation, and how about in Germany? Thank you very much.
Okay. Well, we have a different situation in Germany when there is a community pharmacy or hospital pharmacy. I can say now that in hospital pharmacies, the collaboration with the doctors is really on eye level, and there's no problem anymore to get access to patient data. And for example, in our hospital, we are reviewing the medication of the patients on a regular basis because we are visiting the electronic data files in our pharmacy. We can add a command, and the doctor, he has to adhere to this command and have to check it. Yes. In the community pharmacy, the situation is quite different. But in many cases, the community pharmacists, they have a good standing with the doctors who are sending their patients on a regular basis to the pharmacy. And they can ask and discuss with the doctor. And indeed, how would you say, to get the money from the insurance for prescription, sometimes it's very complicated indeed. And then you have to have a good relation with the doctor so that he can mend the prescription so that the insurance will pay. I would say in Germany, the collaboration between community pharmacists and doctors is very much better than it used to be when I started to work 40 years ago. It's much improved now.
Next question. Can you advise how to a good can you advise to a pharmacist on how to improve a good communication with a doctor? Thank you.
Yes. First thing, the medical students should learn that pharmaceutical students also are present in the hospital in one way or another. That would be an ideal thing, yes? So for example, we are now setting up an internship here for the hospital of Hasanuddin for the master students doing clinical pharmacy. Yes. Then you know to learn each other. Then you learn and you will know each other. That's one of the main things. In our hospital pharmacy, we just start to work with the doctors. And for example, I used to be the head of the committee deciding on the drugs which are being purchased for the hospital. Then you have to discuss with all the doctors around, yes? And of course, you establish relations, yeah? And then when relations are established, you can send out your pharmacists to do some work on the parts, for example, yes. But if you start any project at all, you must be aware that the doctors might challenge your knowledge. And then you stand your ground and things will be okay.
Okay, thank you very much.
Thank you. And I just get the news that we have a question from the Zoom. Okay, we have Khairun from Zoom meeting. He's asking, does the pharmacist in Germany have standard procedure to interview the patient? And can you explain the difference between patient intervention in hospital and in pharmaceutical community pharmacy?
Well, I try. There are standard operation procedures available for the medical reconciliation in the community pharmacy. And it's even introduced now when you do this kind of pharmaceutical service in a community pharmacy, you will get reimbursed by the insurance for the patient. It's possible. And for this being possible, you have to qualify in a certain matter. And again, my colleagues at the table would be better to answer this question, but I can answer it for the hospital, yes. Well, we don't really have, for example, in our hospital, a standard operation procedure or questionnaire to do this, yes. But of course, we adhere to all the guidelines which are existing, yes.
Ya, tidak ada standar prosedur yang baku, tapi mereka punya guideline untuk pendekatan terhadap pasiennya. Tidak ada standar prosedur yang baku untuk wawancara pasien, tapi mereka punya guideline untuk patient intervention. Okay. Hi. I think it's done for this session. Please join me to give a round of applause for Dr. Lutz Vogel. Thank you. Before we move on to the next speaker, I would like to invite Professor Sartini. Sorry? I would like to invite Dr. Nur Hasni Hassan. Please stay on the stage to deliver the certificate and souvenir to our distinguished speaker today. Tunggu Pak, masih ada Kak? Thank you very much, Dr. Lutz Vogel. It's really nice and interesting talk. The second speaker of this morning session, we have Professor Dr. Gatot Hari Priyo Wiryanto, Director of Southeast Asian Minister of Education. Please join, I would like to invite you to join with me here on the stage. Ya? Iya. Tidak ada PowerPoint or tidak ada PowerPoint, Pak? Ada. Mau bahasa dalam bahasa, Pak? Dalam bahasa? Ya.
Mas, yang belakang bisa di setelin tadi? Operator.
We are waiting. Rangga. While waiting the technician to show the presentation, saya ingin mengingatkan Pak Prof, we have 30 minutes talk,
Oke.
30 menit presentasi, and afterwards we have 15 minutes for Q&A session.
Good morning to all of you, to my friend Cruz God. I always talk Grüß Gott because it's the first word in German that I learned is Grüß Gott. That's why if I meet my friend from German, I always say Grüß Gott because it's the first word. But anyway, welcome to Indonesia, and then I do hope that you enjoy Makassar, Indonesia, and please come back again later on, not only in Makassar or Unhas, but also in another university, because there is a lot of university that we need cooperation between Indonesia and Jerman become closer and closer later on. Okay, Bapak Ibu, I want to talk about engineering. Wait a minute. Mana Mas? Operator? Mana? Okay, next. Yang next. In metaverse, okay. I want to say something different because you are all pharmacists or biologists. Think about what we have to do in the future because you talk about the engineering. The title is Engineering Applied Science. Now we try to prepare or what we have to do about the future education. Not only in this room, but also you already know about the Zoom technology, but now there is another level of the education about we just start this year in Indonesia about the metaverse. Ini kemana? Next. Sini ya? Tidak bisa? Okay. Next. This is a sample that we got also from Mark Zuckerberg, from Facebook, but we try to endorse in Indonesia, especially in the vocational school, what we have to do, something like that. You can go to one place, somebody from Jakarta, from Makassar, from Merauke, from Bangkok, in one place like that. We did already since January. We prepare our manpower to know about the technology, how we can learn, study, upskilling, reskilling our skill as fast as possible, massive as possible, because Indonesia have 270 million. What we have to do with the classical way, it's difficult and it takes time and then money, for example. This is what we try to do. This is information. They like virtual room that we have to prepare something like this. Is from the Mark Zuckerberg, but we want to prepare also in Indonesia. Can you imagine? This is avatar that we prepare together. You can go to this room and then you can learn everything. Pharmacy, engineering, something like that, theory, something like that. Wait a minute. Next Mas, itunya klik. Klik lagi, ini nggak bisa.
Next slide.
Next slide, please. Okay. Next, you just click.
Next page.
Next page. This is just information that because we just start in the vocational school and 3, 4, 5 university to join the metaverse. I do believe that we can prepare also in Hasanuddin how we can prepare it. This is a combination of the word from prefix meta meaning beyond and universe. This is that we want to share with you what we can do together, something like that. Now, next please. Oi.
Page down.
Okay, go. Next Mas, kanan.
Ke bawah.
Yes, sir. Next. Next. Next, please. Look this one. This is prepared by our student from Bandung. You can see this room. We can build our room in 1 month, and then you as avatar can join this room. Look this one. This is an example that we prepare together. We already trained 200 institutions how to develop their own building, and then how to prepare the avatar in his house, on his university, something like that. This is sometimes better than the normal building. But we can prepare Hasanuddin, for example. How look it like later on. And the student from Bandung, from Jakarta, from German can easily come here with one click and then discuss with the lecturer.
Okay, good morning. We're again, and today is our last session. Still discussing about the
Increase the
metaverse,
number of the
and
student,
now,
double, triple, without building the like the massive building like this, but metaverse, something like that. That is
I
the
think that is
program that we
related
want to
the
share with
metaverse.
you
Maybe
for
we
this
can
one.
start with the
Next,
first
Mas.
person, yeah.
Terusin
Vicky,
aja.
are you ready?
This is, for example, if you want to show, klik itunya, YouTube-nya. If you want to share what kind of university, what kind of school we have, so everybody can join,
Yes. You can skip.
see what happened in the school, or in your lab, or in your corner, your activity, your special place that you want to share with everybody across the world, something like this. So we can prepare. This is like animation, but after we prepare this, and your avatar can go to every room and then exercise. Oke, Mas. Stop. Ganti yang slide berikutnya. Next. Ganti stop. Stop. Terus yang terakhir, saya yang terakhir, the future education. PPT-nya.
PowerPoint.
PowerPoint-nya. Ada? Sana atau belakang?
Sana, Pak.
Yang PPT terakhir saya kirim, coba jangan. So, Bapak Ibu, adik-adik semuanya, pendidikan sudah mulai berubah. Ini ya. Coba Mas yang PPT yang berikutnya lihat.
PowerPoint terakhir.
PowerPoint-nya. Operatornya di belakang atau di sini?
Sana.
Udah, PowerPoint-nya ada? Ya. Nah, semua yang sekarang kita siapkan, apa yang tak tunjukkan ke Anda ini, sedang lagi berpacu di Indonesia ini, untuk saling networking. Anda bisa bergabung dengan anak farmasi ITB, UNER, dan sebagainya, dalam satu ruangan yang bisa kita kembangkan terus ini. Mana Mas? PPT-nya mana? Nah, itu yang harus kita lihat, seberapa jauh ini bisa kita kembangkan di masa mendatang. Kenapa nggak bisa jalan PPT-nya? Aku udah bilang.
Ya Pak.
Nah, di dalam pengembangan yang akan datang, ini akan terjadi banyak hal yang perlu disiapkan. Anda mau kemana? Anda akan dapat semua informasi. You have a lot of information from everywhere. You can go to everywhere. So easier now. The important things that we have to prepare networking among us. We have to prepare networking among Hasanuddin, Erlangga, ITB, UI, who have the pharmacist faculty, for example. And then, what we have to do in the future? Let me think about this possibility. Let me think what we can do in the future. Because you can go everywhere without you have to use your plane or to everywhere. This is the important thing that we want to share with you in the future. And then what we can do, things differently. Things that you can communicate with people from Germany, from Bangkok, from Thailand, from Philippines. This is the future education. Not only in this room, not only in your lab, not only in the other place that you have to go together, for example. This is, we want to share with you what we can prepare it together with you. Gimana Mas?
Yes.
Okay. Look, next. This is now the global university. Try to prepare networking among them. Can you imagine? There is a lot of money to invest to prepare the world global university. Next, Mas. Baterai habis. Next. And then I just share with you. We prepare with Thailand and Vietnam in Southeast Asia because my responsibility is in Southeast Asia. In the future, lecture and student exchange not only physical, but also virtual. It's easier and low cost for them. Content exchange, what the Professor Vogel tell you this morning and the other, you can hear from German, and then we can discuss like in this room, the metaphors. We thought Professor Vogel go to Indonesia, something like that. Or somebody from Thailand, somebody from Japan, because we just prepare about the time. We agree on the time, Sunday or Monday, 7 a.m. or p.m. We sit together like Zoom, but we come with the 3 dimension and discuss more detail. Next, Mas. We need this about the joint metaverse. This is Indonesian. Okay. We join metaverse room to run the joint program. Let me prepare it together. Now we are in the room that we prepare about international information, international seminar. But later on, let me agree with the Berlin University, Freie University, Aachen University, or Karlsruhe, or München University, LMU. Can we prepare one room together between Unhas and München? Yes. Who prepare it? Let me prepare it together. Who come to this? Let the student in the lecture go together. We did already with the Thailand and prepare with the Philippines and the Vietnam. Like next, Mas. This is, for example, that we invite them and discuss in the metaverse room. There is the list of the students from Indonesia and Thailand who join and discuss what we can do in the future. Next, Mas. This is the college that we try to share, the Universitas Pajajaran, that I'm a lecturer over there, and then also Polytechnic Negeri Elektronika Surabaya. I'm a lecturer over there also as entrepreneur program, because we have to find the talented student who prepare since beginning, since semester 1 to be entrepreneur. Like pharmacy, the potential is there. But you have to explore your ability to be entrepreneur in the pharmacy. For example, this one. And then Pontianak, Bandung, and then also this is small group that we prepare together to go with Thailand, for example. Maybe we have to ask our friend from German. Can we prepare together UNHAS and from Munchen or from another university? Let me do it. Let me prepare it next year that we can prepare together for this room. Next. This is our prediction, higher education. The institution become lower because there is merger. Because of the technology, because of the demand, and then also the student become double for Indonesia. We do hope. And then tuition fee become lowest and lowest and lowest, because no need a building, no need something like this. Joint international institution become bigger and bigger because collaboration is become a must in the future if you want to survive. Next must. This is, for example, that we prepare. We prepare already more than 200 metaverse room that the school can communicate among each other. From Aceh, from Sumatra, Banten, East Java, Kalimantan, for example. This is in the vocational school. Because we prepare young generation who want to join the university or polytechnic later on, vocational later on, to use the new technology, the new era, the new way, how they can increase the skill to get a job, or increase the skill and then get money since the semester 1. This is our challenge. Next, Mas. This is the competition among the students who share the room, and then they got the prize from the governor of East Java, for example. This is, for example, there is a 30 school make a competition, and we teach them to develop the metaverse and then sell the program, and the people have to buy with small money, and then we just count how many rupiah, and then the best one, we got a prize from our government. Next, Mas. This is in Java. For example, this one, the interaction in 12 hours, how they can sell, because this is the entrepreneur program. Next, Mas. And then also this is Kencong. Kencong is near Jember. There's also in 12 hours how they can sell the program and the product, surround them onlinely. Next, Mas. This is also Jember. Next. Nah, disruption education. We just think about disruption education. What's happened? Lecturer and student ratio is different. Pharmacy have 600 students. Can we increase until 1,200? Can we increase until 2,000, 5,000? We thought at the building? Yes, in the future. Collaboration between 2, 3 university, and then depend on the job, depend on the demand of the end user, and then also unit of number student ratio is different. Automation in the upgrade of skill, not all, but once we talk about the automation, about the air condition, can you imagine 10 million car with air condition that you update one part, and then across Indonesia is faster use this technology, and global university with lost high qualities will coming. for Indonesia with 2,270 million population, this is one alternative that we can increase the number of students in the university or polytechnic. And then metaverse everywhere. It's happened now. Next, Mas. Do we need building? No. New building. Do we need library, this classical library? No. Because all the library universities connected each other like in German. During my time in German, I can ask, okay, I want to this book from Munchen or from Karlsruhe. 1 week, the book is come. Physical book at that time, 1985. But now, just click, you can get all the information across the world. Just we need join virtual class, join virtual campus, join lecture, and another. Collaboration is very important in the future. Next, the last one. The motto, education is low cost. High impact, fast content distribution, global virtual university school training center. This is our future. So think about possibility. What happened after you finish your study in UNHAS? What is your job? How much is your salary? Think about it for now. Do I have a job later on? Or I have to change with the Merdeka Belajar Kampus Merdeka? I have to change another subject, 1 semester, 2 semester, 3 semester? Do it. Depend on you. Depend on all of you. Terserah Anda. Manfaatin semester 3 semester untuk Kampus Merdeka belajar yang lain. Jangan ngotot, wah saya harus jadi apoteker, saya harus ini. Enggak, tidak semua apoteker ada lapangan kerjanya. Apotek harus belajar IT, iya. Karena hanya kimia farma yang punya network bagus. Tapi kalau ada 10 apotek yang inventorinya Anda yang kerjakan dengan ilmu IT yang Anda dapatkan karena Anda belajar IT, itu lapangan kerja baru. Pikirkan Anda mau kemana. So think about what is your future? In the coming 2 years, 5 years, do I have new job? Do I have possibility job with this salary? Think about that in Indonesia. Saya kira itu. Terima kasih. Selamat siang. Assalamualaikum.
Thank you very much, Professor Gatot, for nice and inspiring talk about metaverse. It's really interesting because it's something new for us, especially for pharmacists and people who work in university. Metaverse is something new for us because, but it's really useful as well because it can help pharmacists or probably lecturer in university to present lecture in class with something interesting for student, because I think student now more interested in something like avatar. Yes, for me personally, I'm imagining to deliver a lecture in class in more interesting ways. And what I also take a note about this metaverse, it can make low cost, high impact, and fast content distribution. Okay. Before we move to Q&A session, I would like to give brief introduction. I think we missed this introduction. Sorry, I do apologize, Professor. Professor Gatot Hari Priyowiaryanto got his bachelor degree in ITB and doctor in Germany. He involved in many projects around the world, in Cambodia, in South Korea, China, and Germany. He also lectured in some public and private university in Indonesia, and now he is coordinator for metaverse training for vocational high school and high education university in since February 2022. All right, we can have one or two questions from the attendees. I think it's really interesting for students as well, for academics. Yeah.
Ya, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Saya Habib, postgraduate dari Farmasi Unhas. I'm using bahasa. So, pertanyaan saya begini, Prof. Berbicara tentang metaverse, di farmasi itu berbicaranya agak lebih sulit. Karena di farmasi kita lebih ke eksperimental, terkhusus untuk teman-teman S1, kita harus lebih banyak menyentuh. Saya masih ingat ketika saya kuliah S1 kemarin, saya selalu diingatkan oleh salah satu guru saya, profesor saya, dia bilang farmasi itu harus lebih banyak menyentuh untuk mendapatkan feel-nya. Nah, bagaimana caranya? Apakah ada proses pengembangan, development dari metaverse khusus farmasi, Prof? Bagaimana caranya kita bisa, oh ketika kita membelah mencit, oh feel-nya gini. Oh ketika kita pencampuran bahan, oh feel-nya gini. Jadi metaverse memang sangat bagus, tapi untuk farmasi sedikit bagi saya pribadi, Prof, minta maaf, itu masih agak kurang dapat feel-nya, Prof. Apakah ada khusus untuk development metaverse farmasi? Mungkin itu saja. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Habib. He asked about how to transform pharmaceutical study, which sometimes we have experimental study, because we have sometimes we need personal adjustment into metaverse things. Silakan,
Okay.
Prof.
So, in my opinion, my experience, there is possibility, atau itu ada peluangnya. Kita udah pernah coba kimia, reaksi kimia, warna dan sebagainya, H2SO4 dan sebagainya, itu bisa disimulasikan. Itu yang, tapi memang harus disiapkan oleh yang mengerti masalah itu. Dan ini sudah dicoba. Silakan aja, tinggal masalah di Unhas, mungkin enggak itu. So I think we did already in Bandung, and also, but in chemistry, in biology also. But in pharmacy, depend on your content. What kind of content you want to prepare to show your student and how you simulated them. You can ask somebody who talented in the animation, and then also the program. But the content, you have to prepare step by step. What we have to do, A plus B, H2SO4 plus Cl, for example, and the other component. You have to prepare it and then make a simulation and then make animation. Once you have a content, this content, and then is the right, you can distribute the content, the video content or the animation content that you want to prepare to present in the metaverse across Indonesia. This is the benefit. But we have to prepare smoothly, detail, and then with your narration, your information. Look, step 1, the color is red. Step 2, the color is blue. Step 3, the color something. The size of molecule, something like this, I mean like this. And then you prepare it in animation. And then this content, you can distribute to 20 pharmacies faculty in Indonesia. Look, this is one is our product. The other pharmacy faculty, they can prepare also another product. So once you have 20 product that help each other, share each other, and you have content over there. We did already in the high school. So mathematics, for example, once we have a good example and simulation in the video or in the animation, we distribute to all the high school or vocational school with the high standard, the process like that. This is that we can do it together. I think yes.
Yes. Is it clear? Thank you. We can have one more question. All right, I have a question, sir. how long do you, from your experience, how long we need to apply this metaverse into like one small group?
One small room depend on the asset.
Okay.
It's easier 1 week. If you have a lot of assets, maybe 2 weeks until 1 month. That's it. And then our young student is like a play game. This is like a play game.
Yes.
Yeah. And then we train them how with SketchUp, with animation, for example, how you use, prepare the asset and put in the metaverse room, and then like share with you what we did already, something like that. It's easier, but the important thing is the content. How we can prepare the right content, and then how we can invite the other student to join this metaverse room, for example. We prepared
Yes.
already.
Thank you so much. Thank you very much. I think it's really interesting, and I hope probably in the next year or we can adapt this year. We can adapt this metaverse into our academics life. Once again, thank you very much, Professor Gatot. Please join me to give a round of applause for Professor Gatot. Yeah, please stay. I would like to invite Professor Sartini, Vice Dean of Planning, Development, and Finance, to join with us on the stage to present certificate and souvenirs to Professor Gatot. Prof, Mas. Ya, boleh nanti bawakan ya. Once again, thank you so much, Professor Gatot. Now, we have the third speaker of this morning session is Mr. Apotheker Habibi. I would like to invite you to join with me on the stage. He's giving a presentation of his research. Before we start, I would like to give a short introduction. Mr. Habibi got his bachelor degree and pharmacist degree in Hasanuddin University and master degree in Toyama University. He's now, he's giving a presentation. Here's some publication of Mr. Habibi with his PhD supervisor. So before we start, I would like to give you, told you that we have 30 minutes presentation, and then we'll move to Q&A session for 15 minutes. Mr. Habibi, time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for the kind introduction. And first, I would like to express my gratitude to the organizing committee who has given me this great chance to deliver one of my study. So please, the slide. Yeah. Okay. So today I would like to introduce about osteoprotogerin, and later I will could be possible to use as a prognostic biomarker. In this case, we start from bench in vivo and in vitro study, and afterwards, after we receive or found there is evidence that OPG could be beneficial for this, we continue to the clinical setting using some patients of the IPF. So, first of all, I would like to introduce why we are interested to idiopathic pulmonary fibrosis, in this case IPF. Because idiopathic pulmonary fibrosis is one of the subgroup of the interstitial lung disease. So the disease that happens in the parenchymal area of the lung, and is characterized by huge accumulation of the extracellular matrix and also collagen, and it will remodeling the architecture of the lung. And this remodeling of the architecture will hamper the changes between oxygen and also carbon dioxide, and it will severely affect the lung functions, and eventually the patient will die. And one of the problems with IPF is the prognosis of the disease. So most of the patients, when first time they are diagnosed with IPF, the survival time limited only to 2 until 5 years. So if we compare to other diseases like cancer, it's almost similar, whether the prognosis of the patient is really bad. And also the case in IPF, why the prognosis is so poor is, first, most of the patients are diagnosed in the late phase or the advanced phase of the disease. This is because mainly, one is the symptoms of the disease is similar to other interstitial lung disease, which is a lot of coughing and also difficult to breathe. And the thing also, because difficult to diagnose, it takes around 1 year, starting from the patient coming to the hospital until they give, the clinician give the definitive diagnosis. And the problem, again, is because there is no specific biomarker that we can use to see whether these patients really got IPF. And the other problem in here is the misdiagnosis. The patient will receive some medication. Like, for instance, if patient with COPD have same symptoms with IPF, they will receive some dexamethasones or anti-inflammatory drugs. And for IPF, patients receiving this medication is not improving the disease, even is making the disease is worsening. So based on this, we thought that there is an urgent need for a biomarker for IPF. So as I mentioned before, that idiopathic pulmonary fibrosis characterized by huge accumulation of the extracellular matrix. So there is huge accumulation of the extracellular matrix in the parenchyma of the lung, and eventually, because the amount is too high, so these extracellular matrix proteins will also expose to the bloodstream, and this will give us opportunity to take the blood and measure the level of these proteins and see whether it's increased or decreased. And it can be a biomarker for us to diagnose or to see the notion of the IPF in patient. And in here, we are interested to osteoprotogerin, and later I will address as OPG. So originally, OPG is known as a decoy receptor for rankle and also for trail. And the role of OPG is well known by inhibiting either rankle or trail. And it's well known that if rankle bind to rank, and then it will activate several action in our body. One of them is the activation of the TRAF6, and then leads to PI3K activation of the signaling pathway. And in this case, will activates the activation of the osteoclast, and we know OPG is well known as an inhibitor of the bone degradation. So we know that in the menopause women, which have high risk of the osteoporosis, this is because of the reduction of the estrogen production will lead to the reduction of the OPG, and in this case there is nothing that could inhibit wrinkle-induced activation of the osteoclast and giving high risk of the osteoporosis for the woman. And then in other signaling pathway, which is direct coming from the ARC signaling pathway, this is happen in the epithelial cells where activation of the rank will induce the proliferation of several cells like memory and also thymic epithelial cells. And then if we goes to the next is about TRAIL. So TRAIL is well known as inducer of the apoptosis. So in cancer, many cancer cells inhibit the activation of the TRAIL signaling to survive from the apoptosis. And in this case, OPG is one of the proteins that could inhibit TRAIL-induced apoptosis. And this is also the case why many cancer cells which produce huge amount of OPG to interfere the action of TRAIL. And then what we know about OPG in fibrosis. So several studies, including in our group, found that OPG is associated with the fibrotic process in liver or in blood vessels. So as you can see from the slides, so this is a mouse liver slide, and in the y-axis is the OPG level. And in this case, we treat the mouse with the CCL4, well-known inducer of the damage to the liver. And as we can see that there is huge accumulation of the OPG in this mouse model. And then we also took the liver tissue of the patients with the cirrhotic, and then we also measure the level of OPG in their liver. And as we see in the mouse, there is also huge accumulation of the OPG in the human cirrhotic liver. So this is shown that there is association between OPG and also disease in the liver, especially to fibrosis. And then actually in the liver cirrhotic, OPG already used as one of the biomarker in the panel. This has helped the clinician to could definitely diagnose the disease of the patient. So since we would like to see whether this OPG also could be used as a biomarker for pulmonary fibrosis, so of course the first question, could we found OPG also in the lung tissue? So to answer this question, we did 2 experiments. So first we use in vivo model using silica-induced lung fibrosis. So in mouse, we introduce crystalline silica in day 0, and after that, we keep it in the cage for 28 days, and then after the fibrotic development occur, we sacrifice the mice and we collect the corresponding tissue for future experiment. And the other approach is we took lung tissue from control patients and also from patient with pulmonary fibrosis, in this case IPF. In here, the control patients is the patients who diagnosed to carcinoma, and then of course when the clinician do this surgery for the carcinoma, they will took the tissue not only in the area where the carcinoma occurs, also the other area, healthy area. And by our pathology, they will see whether that one is normal, and then we took that tissue for control, because of course you couldn't take control lung tissue from healthy individuals. Yeah. And then, yeah, as what expected, that there is also huge accumulation of the OPG or production of OPG in the lung tissue in mice-induced fibrosis using silica. And after that, we would like to visualize to see the the position or where OPG in this mouse. So as you can see, this is a control mouse. There is no OPG expressed in the parenchyme. We only see OPG. Yeah, OPG shown in red. So we can see OPG expressed in the in the vessels of the airway, because OPG expressed of the smooth muscle cells, and also in some area where, like in the bronchus. But surprisingly, when we see the lung tissue of the mouse induced with fibrosis, we clearly see there was huge production of OPG even in the parenchyma area, where we didn't see it in the control mouse. So this is confirmed that in fibrotic lung we see the expression of OPG. And then from the human lung tissue, that's also we clearly see that there is an increase of the OPG in the IPF patients as compared to the control patient. And if we look closer to the histology of the lung, we see the same pattern as we found in the mouse. So this confirms that in this case OPG is increased in the fibrotic lung. And from the previous slide, the histology, we count the positive staining of the OPG, and we also count the positive staining of the collagen 1 alpha 1. This is a marker of the fibrosis. So in the fibrotic organ or lung or liver, there will be huge accumulation of the collagen 1 alpha 1, and as you can see, there is a clear increased expression of both OPG and also collagen 1 alpha 1. And we also would like to know the source of the OPG in the lung tissue, because this is also important. We have, since OPG is produced not only in the bone, but other organs also produce OPG. And since we would like to use it as a marker, so we have to make sure that the OPG that we found in the liver, in the lung, is produced locally in the liver, in the lung. So in this case, we isolate the fibroblasts from control patients and also from the patient with IPF, and after that we culture for 48 days, and then we collect the medium and measure the level of the OPG that we found in the medium. And surprisingly, we clearly see that there is huge increased amount of the OPG production in the fibroblasts derived from patients with IPF. So collectively, we show that there is expression of the OPG. And the next question is, what is the role of the OPG in this situation, or the expression of OPG is related to the fibrosis? Because we show the expression, but we don't know yet what's happened in there. So to answer this, we employ precision cut lung slices. So in this study, we took the lung tissue of the mice, and then we insert the lung with the agarose to keep the the lung tissue is expand, and then we incubate in the cooled buffer. After that, we make the lung slices. So it's really thin slices of the lung, and then we culture these lung tissue slices. So this approach give us opportunity, because if we use cell lines, it's only one cells, and we know that the hemostasis in the body is derived from interaction between one cell to another cells, also the interaction between the cells and the environment. So with this model, we could provide an intact organ, and then we can see the expression of the OPG in this setting. So from the precision cut lung slices, we would like to see whether the upregulation of the OPG is derived according to the fibrosis development. So because of that, in this case, we use TGF-beta. So TGF-beta is the cytokines that well known as inducer that will drive fibrosis development and also increase the extracellular matrix component production. And then we add TGF-beta to the lung slices and leave it for 48 days. And after that, we collect the medium and also collect the slices itself for the protein and also mRNA analysis. And as we show now in the slides, that there is a huge increase of the OPG mRNA upon addition of the TGF-beta, and it corresponds to the level of the OPG, osteoprotein protein that we found in the medium. And to confirm that this model works, especially whether the TGF-beta also could induce fibrosis in this setting, so we also measure the level of mRNA expression of three well-known fibrotic-related protein, which is fibronectin-1, PA1, and also collagen-1 and alpha-1 mRNA. And it's confirmed that the level of the these three proteins also increase upon addition of TGF-beta1. And the next question is whether this effects that we shown is really dependent to the TGF-beta1, to confirm whether what we show here is really related to the fibrotic development. And in this case, we do the same approach, but we add also galunisertib. So galunisertib is TGF-beta1 receptor inhibitor. So when we add this galunisertib, we will not see the effects of the TGF-beta1 because it can block the receptor of the TGF-beta1. And as clearly shown in the slide, that upon addition of the galunisertib, the increase of the OPG mRNA, collagen-1 alpha-1 mRNA, and other two fibrotic-related protein decrease, or we can see it's return back to the basal level. So from here, we can conclude that the increase of the OPG is related to fibrotic development. And then we also would like to characterize more deep, to dig deeper to the role of the OPG in this machinery. So as I already talked in my previous slide, that OPG mostly work by inhibiting either rankle or trail, and there is limited receptor that could directly bind to OPG. So in this case, we would like to see the role of the OPG in relation to rankle and also trail. And for the trail, we already did several experiments, but we didn't see clear effects in this ligand. So that's why we will more focusing to the rankle for the future study to see the role of the OPG in this fibrotic development. And first, I would like to introduce about rankle. So rankle, or receptor activator for NF-κB ligands, or is a well-known stimulator of bone tissue degradation. So the rankle is responsible for bone degradation. So it will degrade the matrix of the bone. And then OPG in this case will inhibit rankle, so it will prevent the degradation of the bone. And what we know about rankle, except in his regulation to the bone, is rankle found in lymph node, mammary gland, and also the follicle of the hair. And this is really important for the development of the tissue. So in the early development, rankle responsible to the development of mammary gland, hair, and also the lymph node. And related to the lung, there is also several studies already addressed about the expression and also a little bit role of the rankle in the lung. So increased level of the rankle is also found in the ball, is bronchoalveolar lavage of the silica-induced pulmonary fibrosis mouse model. So in the previous study, we used that silica model to see whether OPG increased, and also previous study also found that wrinkle also increased when we induce fibrosis using silica in the mouse. And more importantly, the higher levels of wrinkle also found in serum in the patients of the cystic fibrosis and also COPD. And most recently, in our group also published that there is elevated level of wrinkle in fibroblasts derived from COPD patients. So this is also interesting because it's well known that the COPD patients is also suffer from osteoporosis, and this study at least confirmed that one of the source of the high production of the wrinkle is from the lung. And then, since we know that a wrinkle produced in the lung tissue, and also we know that involved in the epithelial proliferation in the memory and also in the thymic, so we hypothesize that could be that wrinkle also have this role in the lung epithelial cells proliferation. So to answer this hypothesis, so we use organoid assay. So in this case, we took the lung tissue from urine or from human. So the tissue from human is derived from COPD patients who undergo lung transplantation. So we took that lung tissue and then we do the isolations. So what we do, so we took the murine and also COPD lung tissue, and then we do enzymatic digestion, and then after that we get cell suspension. And then from this cell suspension, we would like to specifically isolate the Icopmes positive cells or epithelial positive cells. Before that, we need to deplete CD31 and also CD45 positive cells, because these two cells also express Icopmes positive cells. And after depletion of these two cells, we continue to the specific isolation for the Icopmes positive cells, which is CD32-6 positive cells. And then we culture these primary epithelial cells with lung fibroblasts or cell lines or fibroblasts in the matrigel, and then in the surface of the matrigel we add the medium. And then this system will grow into a 3D culture. So in this case, we will see the interaction between fibroblasts and also in epithelial cells. And then we change the medium every 2 days, and we culture for until 14 days. And then we add soluble wrinkle, OPG, and the combination between soluble wrinkle and OPG. And after 14 days, we count the number of the organoids that develop and also the size of the organoids. So first, I will introduce what we found in the mouse organoid. So as you can see in the slide, the mouse organoid will develop into two distinct different organoids, which is alveolar and also airway organoids. So for the alveolar organoids, it looks like grapes, and also for the airway organoids, it looks like orange. And then we confirm whether these two phenotypes is really epithelial and also the airway organoid. So we use surfactant protein C. This is you can see as a green color, and also we use acetylated tubulin. This is a marker for airway cells, and we can see that in the alveolar we could see that there is a positive for the surfactant protein C, and the same with the airway, we could see positive for the acetylated tubulin. So we confirm that the organoid that we have now is alveolar and also airway. And after that, we continue to count the number of this organoid. And as you can see from the slide, for the alveolar organoids, there is an increase the number of the alveolar in the presence of the 10 nanogram per milliliter of soluble Rankel. And what's interesting, when we add the OPG, which is a decoy receptor, alveolar organoids. However, we didn't see any effects in the airway organoids and also to the size of the organoid. So from here, we could see that soluble Rankel induce the proliferation of the alveolar organoids and inhibit by TGF-beta in the murine organoids. And then we would like also to confirm what happened in the human organoid. So different with murine organoid, in the human organoid, we didn't see the distinct two different morphology between airway and also alveolar. In this case, we only have one morphology, and because when we do the immunofluorescence staining, we only see there is a positive staining for the surfactant protein C, which is a marker of the alveolar organoid. And then we continue to count whether soluble Rankel induce proliferation or increase the number of the lung organoids. And we clearly see that there is an increase of the human lung organoids in the presence of soluble Rankel. And then when we introduce OPG in the system, OPG also completely abrogate the effect of soluble Rankel. So this is the confirmation that what we found in the murine also happened in the human. Yeah. And then to deep further look at the effect of the Rankel, now specifically to the pulmonary fibrosis. So we use the silica-induced murine fibrosis mouse model, and in this case, same as what we do previously, we add the crystalline silica and then we leave it for 28 days, waiting until there is development of the fibrosis, and then after that we add soluble Rankel in the concentration 5 and 10 microgram per mice, and we give it every three times in a week, and then after 42 days we sacrifice and also collect the lung tissue. And after that, we would like to see whether soluble Rankel administration could induce the number of the epithelial cells. So we do flow cytometry analysis from the lung tissue that we have. So we dissociate and get the single suspension, and then from that we count the number of the epithelial cells, in this case Icopmes positive cells, and you can see from the graph when the mice suffer from fibrosis, which is in the silica positive model, in silica hamper the effect of the trial. So that's why in this case, if we would like to use the OPG as a prognostic biomarker, so the first thing that we have to do is to make sure that whether the patients really IPF, not other lung diseases. So that's why in this case, I mentioned that as a diagnosed biomarker, we couldn't use OPG because the level is so diverse. There is even some patients level is the same with the control. So of course, in this case, it doesn't work. However, for the prognosis, yeah, it can help because of course, for the prognosis, you already know definitely that the patient is IPF, not other lung disease. And after that, measure the level of OPG. And when we see that the level is above 1, 2, 3, 4 picogram per ml, so we have to consider that probably this patient will progress more severe compared to the other patients. And also this will really help for the clinician to have a tailored medication, especially for the lung transplantation, because 80% of the IPF patient will go to the lung transplantation, and also because limited of the donor, you have to consider which patient it should be priority and the other patients. So in this case, OPG could be one of early for the clinician to say whether the patient with above this level could be more prioritized for the lung transplantation. So that's, I think, the best way to use OPG as a biomarker. Yeah, thank you.
Okay, thank you very much. I think we can't have another question because we have a limited time. But I think Mr. Habibi will stay here whole day. Then you can ask him personally about his speech. Thank you very much, Mr. Habibi. Please join me to give a round of applause for excellent speech.
Thank you so much.
Before we end this session, I would like to invite the Vice Dean of Dr. Yulia Yusrini, Vice Dean for Partnership, Research and Innovation, to join with us on the stage to present certificate and souvenir to Mr. Habibi.
Yeah, we would also like to ask Apoteker Yulia Yusrini Jabir to give certificate to our moderator this session.
Ladies and gentlemen, thank you very much for your... all right, I think my talk is end now. Before I leave the stage, I would like to thank to our three distinguished speakers, Dr. Luz Fojol, Professor Gadot, and Mr. Habibi. Okay, enjoy your snack. Thank you. Have a nice weekend.
Okay. For the next session, we will have presentation from Dr. Tommy Julianto from UITM Malaysia via Zoom meeting. For this session, will be guided for Apoteker Nur Hasni Hasan, PhD. To Apoteker Nur Hasni, time and press are yours.
Thank you, MC, for the pleasant introduction. Assalamualaikum warahmatullahi wabarakatuh. Yeah. Good morning, best wishes for all of us, ladies and gentlemen. Welcome back to the second session of today, Icopmes. My name is Nur Hasni Hasan, and I'll be your moderator for this session. This is the second international conference on pharmaceutical material, engineering, and applied sciences 2022. This is the second time the Faculty of Pharmacy Universitas Hasanuddin has held this conference, and this year the conference brought up the theme addressing challenges and technology and pharmacy for better future. For that, we have two speakers in this session who are already with us via Zoom, right? Yeah. We will have Dr. Tommy Julianto from University Teknologi Mara, Malaysia, and then Dr. Adnan Haider from National University of Medical Science, Pakistan, who will be joining with us later on. Before that, I would like to greet Dr. Tommy. Where is the...
Halo, Assalamualaikum warahmatullahi wabarakatuh.
Where can I see? Okay.
Ya, Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi.
Yeah, good morning, Dr. Tommy.
Morning.
Great. Then, before getting into the main event, I would like also to greet the audience in the meeting Zoom. I hope the audience still attend this seminar with the great enthusiasm like the first day. Then before going to Dr. Tommy presentation, I would like to read the Dr. Tommy profile. Dr. Tommy is a senior lecturer and researcher at the Faculty of Pharmacy, University Teknologi Mara. He graduated as a pharmacist in 1994 and then master in pharmaceutics in 2000 and PhD in pharmaceutics nanotechnology, majoring in nanotechnology in 2014. Currently, he is a lecturer in pharmaceutics at the Faculty of Pharmacy since July 2001. He has published and presented in conference of more than 100 articles and proceedings at national and international level. It's interesting, he has his concept as a scientist. The sweetness achievement as a scientist when we can successfully bring up our idea on the benchtop to commercialization. All right. I would like also to give some guidance for today's session. So we will have this session till the next an hour and a half. And then for the speaker, you will have 30 minutes of presentations following by 15 minutes Q&A session. And then for the audience or participant in the meeting Zoom, you can also ask questions. You can chat in the chat room or by raising your hands. Either way is okay. And then, all right. Dr. Tommy, are you ready for your presentation?
Inshallah, ready.
Okay, please, time is yours.
Okay, thank you very much. Okay, maybe can see from there presentation. Okay. Firstly, I would like to thank and congratulate also Faculty of Pharmacy, University Hasanuddin, Makassar. Unfortunately, I cannot join the conference in Makassar since I have preparation to go to Umrah next few days. Yeah, but I I'm happy still can share my experience here on research and also collaboration research with the industry. So my topic here put a little bit general, not specific to some certain research. Yeah, this based on my research experience also and how handle problem in industry. So the topic is given today in the soil friendly of machine production technique for pharmaceutical and cosmetic applications. And wait, look like not moving. Okay. I'm sorry. I try to find the problem here because the slide not moving. Okay, can move now. Maybe I give some light introduction about the non-immersion and then talking about the problem that we have when we use non-immersion. So totally the basic if we use non-immersion totally initiate maybe from delivery of lipophilic active into human skin from skin in the pharmaceutical and cosmetic application. Yeah, it's really not only to skin but also to GIT. But in this case, in this today presentation, maybe I touch about the skin penetration delivery of active. If we have lipophilic active, at least we have the difficulty to deliver them into the skin tissue, especially when just go to the epidermis and dermis more difficult, because the size of the molecule and then also the solubility of the molecule. When using conventional formulation like macroemulsion that we fluent as a cream or maybe hydrogel, we cannot enhance the absorption. We have limitation because it's not easy to pass through the skin barrier. And in other condition, we need certain concentration of active to be have pharmacological effect or effect in the cosmetic side. Okay, and then when we have transition different technology 2 decades ago from macro immersion to non-immersion, and then tracks the industry to invest in the new technology. Since non-immersion, they have quite interesting size range. It's around 200 nano. We can consider below 1000 nano, but mostly companies you go around 20 to 200 nanometer. Due to the character size, especially the physical look of the non-immersion is like what I call in the translucent and transparency. Okay, and then the nano-immersion mostly when the size become 100 nano, it's like almost clear, almost like transparent. You can see the left side here, the picture when differentiate macro immersion and immersion. So look interesting because it can pass through the bottles. Okay, and then one good thing of immersion, we can grant the stability of the immersion during storage, and then this will be advantage if we produce a product with small size but they have better stability. However, in the industry itself, in the pharmaceutical or personal care or cosmetic, they have some perception that to produce an emulsion is expensive. I think this is not only perception, but it's fact, because the equipment we use quite expensive, quite expensive, and then also the equipment to evaluate, to prove the finished product is a non-emulsion also expensive. But in the industry side, in the production side, and maybe investment of machine to produce an emulsion become hassle for the company because you need to spend a lot of money, and also the maintenance, because some part of the in the system also need to change every cycle of use. It's like part or in airplane, and the price also is not cheap and quite expensive. But some the spare part we need to import from Europe, and then we need to purchased in euro. So you compare back to Indonesia, in rupiah, then become very expensive, and then this will affect the finished product price. And then in industry also, they have lack understanding about the mechanism. So they're just thinking only maybe to produce an emulsion, we need to use equipment. Tali, we have an approach to produce an emulsion without using high-tech or expensive equipment, by using knowledge based on interfacial tension of oil and water, and then also a combination with surfactants, and then we can produce non-emulsion in a cheaper way. But only when evaluation, we don't need to invest in the initial stage with like particle analyzer or ECM. We can give this job to the university who have this facility. Okay, just to compare between non-emulsion and macro-emulsion in terms of size, yeah, non-emulsion could be around 20 to 500 nanometer, and then macro-emulsion around 1 micron to 100 micron. And then we have another name of non-emulsion. Last time in 1960, when you still not familiar with nano-emulsion, the emulsion with size 10 to 100 nano, we call it microemulsion. But today, most researchers call them as nano-emulsion. And based on the method preparation, at least for macroemulsion and emulsion, you can prepare by using high and low energy methods. The high energy method, usually we're using mechanical machinery to produce them, usually using pressure to produce them. And then like microemulsion, actually is just using simple approach of formulation by find out a composition of active and then oil phase and surfactants to be a liquid, and then after that, when we introduce into water, they produce emulsion with the size range below 100 nano. And we can say that the field who start with nano-emulsion in 1960 Italy is agriculture, it's not pharmacists. Yeah. So they produce some pesticide by using this system, and then produce an emulsion. And then at that time they call micro-emulsion, and then used widely in agriculture. Okay, we touch about non-emulsion totally is we always call it non-technology, it's a matter of size only. Regulations say that non-emulsion consider 1 to 100 nano, yeah. But some scientists prefer the method below 200 or maybe below 600 nanometer. So in pharmaceuticals, actually, the good thing of nanotechnology, either in emulsion or solid dispersion nanodispersion, they can increase availability at the disease site. Yeah, that means increase bioavailability. That is very important. That is a problem in pharmaceutical, actually. And then can minimize drug degradation loss, and then also can prevent the side effects, especially for when deliver like anti-cancer drug into the human body. And then for topical, the good thing is fast penetration into the skin. Yeah, even rough skin can penetrate. Yeah, when the size becomes small, and then can deposit uniformly the active on the skin of epidermis. And then at the end, if the amount of active a lot quite high in the site of action, then will increase the efficacy. Yeah, this one comparison. What is nanoparticle that is available? Yeah, that people use in many fields. Yeah, could be physical like liposome, and then also a nanolipid carrier, and then polymerics, nanoparticle. Yeah, and then if they are solid dispersion, could be gold from silver. Just only to show you. Yeah. Okay, in our side later on we discuss more about the nano-emulsion. Okay, this affect drug size here on the premise of the active component, the skin. Yeah, so really depend on the size of the particle, either in solid dosage form or liquid dosage form like nano-emulsion. So you can see here conventional delivery. Yeah, most the droplet will be deposited in the top of the skin. Yeah, and then after that the delivery can be enter a bit more inside the stratum corneum. And then a lot actually animation in the market could be in the herbal formulation, yeah. Some of them in the for the drugs, yeah. But just put a few example here. For example here, and then maybe we go directly to the production, mechanical production of the nano-emulsion. Since we have 30 minutes, yeah, 30 minutes is very short, so I try to elaborate what we need to know about this thing. And then mostly mechanical machinery to use to produce a nanolipid television like emulsion, maybe nanolipid carrier. Mostly people use high pressure homogenizer and then microvalidizer. This is most used in industry and also in the lab also. Yeah, and then we have other equipment can use ultrasonication, but maybe we limit by the volume that we can produce. Yeah, but if using high pressure homogenizer and microvalidizer, we can produce in a large volume. Then probably we have these all three systems in the lab, then helpful us to understand how to produce non-emulsion. And then in producing an emulsion using this system, we use pressure, high pressure. So from macro emulsion, we push them to pass through one small hole, and then we'll generate the turbulence, and then we'll produce a small droplet size. And usually the pressure can up to 2000 bar. This very high energy, yeah. And then the impact is for the maintenance of high pressure monitor. Actually, they have one part here. We call it impact ring. Impact ring must be changed after certain cycle use of high monitor. And then the price is not cheap. Although it's small, yeah. One piece around 3,000, yeah, 2,000 to 3,000 euro. So if multiply by ringgit Malaysia, let's say in Malaysia, they more 10,000 for one unit. So if you use for the machine for 1 month, you have to change this part, and then the system become very expensive to produce an emulsion. Okay, then this we have ABC model totally is done based on the pattern that they have in a different brand, yeah, but the principle is same. We must pass through the macro emulsion to small hole with high pressure, and then we'll trigger turbulence, and then we'll produce a small size particle. And this process really is not one cycle, but it's really involve maybe 5 to 10 cycles. And most of the time they get heat. And then this heat sometimes is stable for active who sensitive to high temperature, especially like antioxidant, like vitamins, to produce as non-emulsion by using this high pressure homogenizer. And same thing also, microvalidizer have the same concept. They're using high pressure homogenizer, and then also repeating cycles, yeah, repeating cycle. Then they have part also similar to high pressure homogenizer. We need to change routinely, yeah. And then the cost also is not cheap, yeah, not so cheap. That's but the result of these two machines produce quite high, quite good, and then very stable. And then the problem only later on in the finished product will affect the price. Okay, another method is ultrasonification. Yeah, ultrasonification totally also a quite good system, yeah. But limitation maybe the volume they produce maybe is not how to say comparable to industrial level. Yeah, but in experiment in the lab maybe we can produce this in small scale. Okay, and then we take a look first others nano-level system beside nano-emulsion. So at least audience, student maybe know what else beside nano-emulsion. Liposome maybe some of us familiar, yeah. This one liposome can load. It's not only oil and water active, yeah. So we get to look here. Italy is the phospholipid molecule that forming a layer, and then when they become spare, we call small innumerable vesicle. Yeah, we can put this at the center is aqueous active, and then the layer we can put lipophilic active. Yeah. Okay, and then the preparation of liposome also almost similarly with nano-emulsion, but a bit different only at industrial stage. Yeah, we need to put prepare bilayer sheet of mixture, yeah? And then after that we need to hydrate with water, and then we reduce the particle by using high pressure combinator. But we can also use ultrasonic when we have small volume. And then this example a liposome that use external carrier. So later we can compare with the nanoemulsion how they work. Okay, the problem of liposome tali is loadings capacity is quite low. Yeah, if get around 5%, that's very good already. But in case in practice, the treatments loading capacity only 2 to 4%. Okay. Then in natural product now a lot in market that they call it cipitosome. Naturally they use herbal as the active, and naturally herbal they use is very potent. With small concentration, we give some effects. Okay, in this case, liposome will be useful if you use only a small amount and then gives some effect. Yeah, then could be easily commercial in the market. Okay, and then other form of nanocarrier, just to let you know, is nanolipid carrier and solid lipid nanoparticle. Yeah, for nanolipid carrier and solid nanoparticle, they are same thing. They are lipid. We transform them to be nano droplet. Yeah, but in the form of solid. Yeah, but in production, the solid lipid, we need to melt them first, and then we need to make them emulsion in high temperature, and then after that we return back the temperature of dispersion, nano dispersion into room temperature to form nanolipid carrier. So as I saw here, the method how to make them, totally preparation almost similar to preparation on an emulsion, but we produce them in high temperature. We can use ultrasonication, we can use high pressure homogenizer, and at the end we'll produce nanosolid dispersion. And this involves high temperature, and then this one will be not suitable for lipofatty active that's sensitive to temperature. Okay, and then the advantage of nanolipid carrier, they can like load some active here, some active, and then we can have capability like nanoemulsion to reach the site of action, and then they have high active loading, and then they can prolong the release here. This is a good thing for nanolipid carrier compared to nanoemulsion because they form into a form of solid, and then they can have control release behavior. Okay, and this about lipid carrier. Now we go to nanoemulsion. This is totally the main topic of we have here today. Nanoemulsion we have attraction actually in skincare, cosmetic, because we use only very low concentration surfactant in formulation, and then fast absorption compared to conventional formulation, and then can enhance skin penetration of polysoluble or big molecule weight active. This include drug also. And then also they can deposit uniformly in the epidermis, and then this system also they can penetrate rough skin surface. Yeah, then this very good performance of an emulsion. And then in terms of physical look, yeah, because the fluidity nature of an emulsion, yeah, will give aesthetic character and skin feel, especially for cosmetic when produce them serum or maybe essence of toner. Yeah, this will give advantage in marketing, in promoting the product. And we can use also nanoemulsion as a delivery of fragrance. Yeah, so instead we use alcohol, we change them in the form of nanoemulsion. Yeah, and then also since nanoemulsion can good in the stability. Yeah, and then we can substitute liposome and other vesicles to be nanoemulsion. Okay, and then for nanoemulsion can prepare by many methods. Either we're using emulsion, inversion point methods, or maybe phase inversion temperature methods. Yeah, these two methods quite long already. Then quite effective also to produce nanoemulsion. Maybe some of our audience know about this method. Yeah. One is only based on the phase inversion of the oil phase and water phase. Second one involves temperature. Yeah, both of them totally can produce an emulsion, but to use in industrial application, this method to be tedious. Yeah, in that we need expert to have good understanding and then to control to ensure the quality of non-emulsion from batch to batch. Yeah, and then another method is actually using spontaneous emulsification of lithotropic phase and isochromatic mixture of oil surfactant. So this one is a little bit simple. We just have oil, we have surfactants, and then we have the active. And then the active supposed to be lipophilic active, lipophilic drug, and then we need to make them miscible or dissolve in the oil. Then after that, we transform them to be pro-nano-emulsion, and then this pro-nano-emulsion we just introduce into water to produce an emulsion. We don't involve too much energy, yeah, too much energy just do mixing. Except in the formation of the lithotropic phase, we need temperature and energy, but it's not high like when using high pressure homogenizer. Okay, so the dimension for spontaneous emulsification technique, actually we can produce by two techniques, like I mentioned to you just now, by formation of lithotropic phase system, where we can load the lipophilic active there, and then they are in the form of nanophase gel. Yeah, the meaning here in production we not directly produce nano-emulsion, but we produce lithotropic phase system. We call it nanophase gel. And then this gel, when we introduce the water, yeah, with or without help of agitation mixing, the lithotropic phase will disperse the oil and water in the form of nano-emulsion. And then we have another approach. Actually, we produce a pro-nano-emulsion that we call isochromatic liquid of self-nano-emulsion systems. Tali, this one is more simple. We don't involve any heat. We don't involve any energy of mixing. Yeah? If involve mixing, but only very low energy of mixing, we just need to find out the right composition of oil, water, oil in surfactant, and usually we have co-surfactants, yeah, to mix them to be isochromatic liquids. And then this mixture of liquid, when introduced into water, yeah, immediately they become non-emulsion. Yeah, so most of the time we just left them for half an hour into the water. Don't give agitation. The emulsion, non-emulsion, they form by themselves. And then if you give the bit agitation, they make them to be more uniform in the system. Okay, this both actually will become one approach that very good for industry, that always worry about the investment in the machinery to produce nano-emulsion. But when we produce emulsion industry, we not only thinking about finished product we produce, but we need also to think about how we're going to evaluate them. We need to prove our product that we claim non-emulsion should be non-emulsion. We must have scientific data to prove that. Then we need to have some equipment. Okay, this one a little bit I saw you simple approach to produce non-emulsion. We just used a simple ternary diagram. We put surfactant, co-surfactant on our face, and then after that we do screening. Yeah, we do screening, and then the screening quite fast. Yeah, maybe 1 day, 2 days, and then you can get some area that can produce nanophase gel or isochromatic liquid mixture. I believe some of audience know about that, how to use ternary diagram. Usually we use information on emulsion, or maybe in chemistry they use when to see miscibility or solubility of certain compound in one or two component. Okay, this example we conduct in our labs here. The left side actually is to produce nanophase gel. Nanophase gel, we do screening, and then after that we get data when the composition they become nanophase gel. So if we become nanophase gel, definitely most of the time we produce emulsion with droplet distribution in nano-size range. But as you can see here, this area will produce an emulsion for sure. This one will produce macro emulsion, and then this one the field formulation, they just produce two-phase mixture that we cannot do anything. And then we have also isochromatic liquid here, this area, but when we introduce it into water, we'll produce a separate oil and water. So we will not produce any emulsion here. And then we have also another approach that I mentioned to you before to produce acyclic liquid system. Um, this area this composition, this area will produce nano-emulsion, and then the outside of the area will produce macro-emulsion. Outside of this will not produce any emulsion. You produce only two-layer liquids. Yeah. So this how we how we screen the formulation of composition. And then when we do the screening, actually we not do in the only one type of composition. We vary the composition. We do multi-layer experiment. Yeah, if this picture, if we do by manual, but in practice we using software like design experiment to help us to get some area that can produce nano-emulsion. So I just give example. After experiment using design experiment software, we get which area that can produce nano-emulsion. For example, these triangles, the center here, we take as a example. We evaluate in software design experiment. We study which composition that that have tendency to produce low temperature, low droplet size and low polydispersity index. Yeah, and then from here we make more accurate, more detailed of the formulation that can produce an emulsion. So in this area that we get from the first data, will be almost 100%. Will produce nano-emulsion with smaller polydispersity index and also smaller droplet size. So actually in experiment we just prepare only compositions in this red point, but any composition that you try in this area will produce similar result what it mentioned in the design experiment result. Okay. And then after we get the formulation, and then we go to drug loading. So we go to drug loading. We have another phase or another challenge, how to insert the active into the formulation. Mostly we insert into the lipid oil phase, and then after that you need to do adjustment. When we do adjustment, will affect to the finished product. There could be produce a big size and also big PDI, and also effect to the physical stability, especially when the temperature suddenly change. We become above plus 30 or below minus 30. Sorry, in the range of minus 30 to plus 30. So if they close to zero, stability rate of fluctuation will become increased. So the challenge here only when we introduce the active into the system of nano-emulsion. But by adjusting the formulation, mostly based on my experience, we can get a stable emulsion. Okay, so now this a little bit of explanation how look like the nanophase gel. You can see here left side is like gel. Yeah, this how look like the nanophase gel. Yeah, actually consists of oil, surfactant, and glycerol. Don't have water here. So we replace water with glycerol to allow to form from concentrate nano-emulsion. Wetly we make emulsion with saturated surfactant with minimum water present into the system. So water represented by glycerol, and then this glycerol, and then we introduce the water, immediately they produce nano-emulsion. So it's just like dilution process only. So totally the process to make them totally by mixing to make lamellar layers, and then when we introduce more surfactant into the system, we will convert to the tubular, and then after that at the end will cubical phase. This cubical phase will have tendency to be easily dispersed in water, and then we'll have the tendency to form very small droplets size here in emulsion. Okay, this example, this based on my experience in industry. This one example of beta carotene. This one, the beta carotene is side product in production of tocotrienol from palm oil. Last time this beta carotene become waste product, don't know what to do by industry. Then after that, we collaborate with them, and then we produce them to be self nano emulsifier systems of beta carotene, and then this color is like is yellow light or orange light can be used in a drink. Yeah, it's like addition color for orange. Yeah, and then beta carotene become more useful in application. Okay, and then this an example. This palm tocotrienol. This my recent project with big company in Malaysia. Actually, we produce palm tocotrienol that can be easily dispersed in water. That means if we take this palm tocotrienol in capsule, we swallow into our stomach, and then with glass of water, and then just leave it like that. After 15 to 30 minutes with help of agitation of stomach, then the system will transform to be nanoemulsion, and then will be easily absorbed into our gastrointestinal system, and then easily can go to the blood circulation. And then compared to the conventional, the tocotrienol can be absorbed only 20 to 30% by our gastrointestinals. So we can save the money of stomach. When they purchase something, they can get benefit from what we will purchase for the product. Okay, this does comparison. This nanoemulsion, this one liposome. Yeah, this to let some audience be not aware. Nanoemulsion mostly liquid oil. Yeah, and then where you can load only lipophilic active. And then for liposome, we can put lipophilic, yeah, between the layer. We can put also hydrophilic active at the core of the liposome, and like solid lipid nanoparticle or non-lipid carrier. Mostly, we can load lipophilic active. Yeah. In some case, nanoemulsion, we can make them. It's not only oil and water, but we can also make water in oil in water. So we have droplet water inside the core lipid. Yeah, but this method more difficult to prepare, but possible to prepare. Okay, and then in terms of concentration, yeah, I just pass through. First is particle size distribution. Yeah, we need equipment. If industry don't have equipment, this one we can use facility in university. Some university have it, like ITB have, and then UI have, UHAMKA have, UII Yogyakarta have, and then I think in BRIN also have the system. Okay, and then usually we use two particle analyzer to evaluate the droplet distribution of nanoemulsion. First, to check whether the nanoemulsion is real nanoemulsion. That means no particle outside of 200 or 300 nano. So you can see here distribution is solely only below 300 nanometer, and then we see the rest, no particle contribute into the diagram. That means this one is nano. If we confirm this nano, and then after that we go to using nano synthesizer to confirm what is the size that we have here. Here, the particle size analyzer by using nano synthesizer, we can get a freeze size around 53. This one actually one of my project by using Lempuyang. Actually, it's not Tempuyang, it's Lempuyang. This one is Indonesian herbal. Okay. And then to check stability, usually we check the zeta potential. Yeah, zeta potential here, maybe they have -14. This considered not stable. Then to improve the stability is very simple. We need to increase the viscosity, especially when make them to be a hydrogel in topical application. Then this will enhance the stability. Okay, and then if you want to prove the morphology of droplet, yeah, we need to use either SEM or transform electron microscope. Both can be used, yeah, and then to prove to get some morphology of the particle or droplet that we produce, yeah, whether in the nano size range, yeah, and then we can see, we can measure the diameter, and then we can look like how like the physical characteristic of nanoparticle or nanoemulsion we produce. Okay, maybe problem in nanoemulsion is oswald opening. Yeah, oswald opening tell the tendency of small particle absorbed by big particle in the nanoemulsion, and then this process will be continuous, and then will lead, yeah, to the collision of the oil. Yeah, so this could be happen if the system not stable. Yeah, if the system stable, and then also opening can be prevented. And then we have also another stability analyzer using Lemifus. Lemifus based on measuring the separation of nanoemulsion, actually oil phase and water phase, just centrifugals. And after that, we put a specific tube here. And then after that, we rotate. And then we have infrared light here. We'll beam to the bottoms, and then here they have some detector, and then this detector will detect in certain time, yeah, let's say for 6 hour, 12 hour, and 24 hour. By this thing, we can detect any creaming will be happen. So we don't need to wait 1 year to 2 year to see separation on emulsion. We can do in 24 hours in our lab only. So this one of analysis that can help to check the stability of non-emulsion. Okay, and then maybe I touched a little bit Indonesian herbal. Indonesian herbal totally is quite huge. A lot of them, they have benefit. It's not only for health, but also for cosmetic. Compared to China, they have only 13,000 species medicinal plant. Yeah? Compared to us, we have 30,000 species in our medicine plant. China, they have 100,000 herbal formulation. They can prescribe even. Yeah, compared to us, this number we cannot achieve until today. And then owing to this problem in our country, some potent herbal extract in Indonesia, they're not really optimized. A lot of them optimized by other country, by Western country, that we let them happen for many years. Yeah, because our poor knowledge in advanced technology of formulation. So, and then give us one example, few example like candidates in maybe poor water soluble, maybe they are lipophilics, and they have a fermentation in human skin that maybe can use for pharmaceutical application or cosmetic application. And they have a lot really in our country, but we need to bring up them in better technology, and then this one could be used for our people. And then since I mentioned about this herbal, yeah, maybe I think time's already almost finished. Yeah, I just go direct. Yeah, this only some picture how we extract our herbal in our country. Yeah? So mostly we still use number 7, number 6, and number 5, and number 4 in our extraction of herbal. Yeah, none of industry go to more advanced methods like SVE. Yeah, because SVE is one method that we can extract as herbal. Especially we can gain some herbal that have lipophilic behavior, that they have potent in application, either in skincare, cosmetic, or maybe in health application. Okay, so maybe this is just example. Yeah, if we can make like some herbal with have that will have lipophilic characteristic by using supercritical fit extraction. Yeah, and this one will we be able to produce material that could be favorable to be formulated into an emulsion, because it's most of the extract we produce here is very pure, because we use carbon dioxide as a solvent, and then we extract them in specific condition at temperature only a little bit 31 degrees Celsius, and pressure around 74 bar, and then the process is very fast, around half an hour, and then we can get this very quality extract that may be it's more pure compared to the conventional extraction. And this method now used a lot in Western country. Yeah? Then most of them they extract our herbal They bring the raw material here, bring in the country, and then after they send back to us to sell in a very high price. Okay, and then the good thing of SP extract, even they not formulate into a nano emulsion, is just conventional emulsion, they get better effect. And then when we produce in the form of nano emulsion, we get is very good product, in terms of absorption, in terms of the texture, in terms of permeation into the skin, and then we give better effects. And in terms, sometimes we talking about, I always got some question from industry. If I use nanotechnology, what is this impact to the finished product? Totally, the most question is about the amount or the dose. Is it need to do dose adjustment in the application? Yes, of course. When we use conventional formulation, maybe only 10 to 20% can be absorbed. Then when we use nanotechnology, maybe around 80% to 100% absorb, and then we need to adjust the dose by reducing the dose, and then we'll give some effect. Okay, and then if we produce a product for non-emulsion or any nanotechnology carrier, we need also check also about the toxicology, or maybe some irritation effect that maybe could be happen, especially for skin delivery. And mostly when we use non-biodegradable material or natural material, mostly based on the data that experience is not harmful to humans. And then in this case, we need also have the attention. If produce non-emulsion, we need to use all of them, if possible, consider as grass or general, regard as safe, maybe using like portable ingredient like oil, and then so that is used in food, and then to produce the emulsion. Okay, in summary, the use of the spontaneous emulsion technique in the production of emulsion by industry will give more benefit in terms of efficacy market. Only the industry need to know what to do, and then you must have a partner like maybe consultant from university, from researchers from university, to guide them to produce this type of product. Then inshallah, Indonesia now, a lot of industry go to this phase, to have the product in the form of nano cell strength. So they will not want to be left behind from the other country. So I think that's maybe my selling at this time. Thank you very much. Okay, one more forget. This one based on my my research. This one is when we study effect of the droplet size into the red skin abdomen. We can see the difference when we design the emulsion at the size 100 nano, 500 nano, and 1000 nano. And then this one, when we prepare after traceable also, we can see effect of the size of the droplet. It will be effect to the active level in blood. And then this one, another example, if we use for oral, mostly more than 2 times increase in terms of bioavailability. Okay, I think that's all. Thank you very much. I hope I not pass the time given by the committee. Thank you very much.
About the new technique, supercritical fluid expansion for the natural product. All right, now the Q&A session. We would like to invite you to give a question, maybe only one because time limit. Is there any question? What about in the Zoom meeting? All right. Yeah, Dr. Tommy, I actually have one question. I saw in your presentation about the comparison between nano-emulsion and micro-emulsion. And then I saw some data, but I'm wondering why nano-emulsion has a bigger size compared to micro-emulsion. So I don't know, I saw in the third or fourth slide, can you?
The comparison of the, okay, tadi like I mentioned in my presentation just now, okay, I will share this part, yeah, maybe, okay. In the table, right? Yeah. Oh, wait,
Can
this.
you
Okay.
share it?
Yeah, I share it already. You can see, not?
Unfortunately, I cannot see organizing committee. All right, this one.
All right, yeah,
So
this one. Okay.
the middle one and the left one, right one. Okay.
Yeah, okay, maybe just give some clearance about this one. Microemulsion is not micrometer. This definition given in 1960 when the emulsion we cannot see by using microscope, but the emulsion, because that time we don't have equipment to see particle size below 100 nano. So that time we call microemulsion until 1980, 1990s, yeah. And then when we have better equipment to evaluate the droplet or particle of nanoemulsion, and then we can see the size of nanoemulsion. So that time they define a nanoemulsion by FDA example, yeah, is below 100 nanometer considered as nanoemulsion. This term of emulsion that time used by agriculture people, yeah. But in pharmaceutical, they always call this one as nanoemulsion. So don't miss about microemulsion with macroemulsion. Macroemulsion in conventional emulsion with size around micrometer. I hope I explained you are curious about this matter.
Okay, thank you, Dr. Thelmy.
Okay.
If there's no any question anymore, I think we can wrap up the Dr. Tommy session. So please join us with me to give the big round of applause.
Okay, thank you very much.
Okay, next session maybe the certificate. So we will invite Dr. Yulia to give the certificate, online certificate. So,
Hello,
Okay.
Dr. Tommy.
Yeah.
Yeah.
Yeah, hello, Dr.
Hello,
Lia.
yeah. Yeah, unfortunately you're not here with us, but anyway, I can just give this our token of our appreciation to you as a presenter today. So thank you very much for contributing today, and hopefully we're gonna see you next year.
Yeah, inshallah. Thank you very much. Yeah, I'd like to thank for the opportunity for me to give presentation today. Thank you very much.
Thank you.
okay, thank you, Dr. Yulia.
Dr.
Thank
Tommy,
you, Dr. Tommy.
thank you for your nice presentation. I hope that you can come, you can visit us in Makassar. Yeah?
Yes,
Yeah.
I miss Makassar. I miss the seafood.
Yeah, thank you.
Okay, thank you. Bye bye.
Thank you, Dr. Tommy. See you next
Okay,
time.
welcome. See you.
All right. Still in this second session, I would like to greet Dr. Adnan. Are you there, Dr. Adnan? Hello.
Yes, I'm here. Hello. Yes, I'm here. Hi. Good morning.
I'm sorry, I cannot see you.
Can you hear me?
Yeah, I can hear you, but I cannot see you.
I just turned on my video. Now you can see me.
All right, okay. Hello, Dr. Adnan. So for this session, we will have Dr. Adnan Haider from the National University of Medical Science, Pakistan. Hello, Dr. Adnan. Okay.
Hello, how are you?
All right, I will read Dr. Adnan profile. Dr. Adnan Haider, or Dr. Haider, is working as an assistant professor at the Department of Biological Science, National University of Medical Sciences, NUMS, since 2020 till now. He has also worked at Department of Chemistry, Kohat University of Science and Technology. His research work focused on development of metal nanoparticle, synthesis of biopolymer composite, and electrospun nanofiber for biomedical and environmental application. Dr. Haider has a total of high-quality article, including book chapter and book. It's interesting. Dr. Haider has currently more than 3,000 citation with the H index of 28 and I-10 index of 44. Dr. Haider also did postdoc from Yunnan University, Daegu, South Korea. All right, Dr. Adnan, you will have 30 minutes presentation, and then after that we will have a 15-minute Q&A session.
Okay.
Okay, time is yours.
Okay, thank you so much. Can you see this share screen now?
Or can you share screen from your?
Yeah, I have already shared.
Okay. Yeah, we can see the presentation. All right.
First of all, good morning, good afternoon, good evening, wherever everyone is listening to me. And thank you for the such nice introduction. The topic I'm going to present is biofunctionalization of NHA-PLJ hybrid nanofiber scaffold for bone tissue engineering. That is solely for the tissue, bone cells regeneration, enhancing osteoblastic cells activity and suppressing osteoclastic cells activity, that is bone resolving cells. In this slide, this is a brief summary of my presentation topic, in which I will just briefly introduce electrospinning, then stepwise all the work done using hydroxyapatite and PLGN polymer during the electrospinning process. So basically, I will be presenting 4 research articles and introduction of electrospinning and the parameter which affect them. This is the schematic diagram of electrospinning processes, in which you can see 4 main components: syringe pump, power supply, collecting drum, and the process start when we supply the electric current. It causes the charges to flow in the direction using the syringe pump. And here at the tip of the needle, a Taylor cone is formed, where you can see Taylor cone. And from that, if you supply further power voltage, so that stretches the polymer solution and it flies all the way towards the collector. But if we make some if we don't have optimized, if the parameters are not already optimized, then we can get we can't get the proper fibers which we are intending to do and to achieve the desired goal. So for that purpose, every parameter should be properly optimized, cause if any one of the parameters is not optimized, the process will not work. Few of the parameters which are effect of applied voltage. So if we supply too much voltage, Taylor conformation, it will affect the Taylor conformation. Similarly, here you can see if you properly apply the optimized voltage, you can get a Taylor con and then a jet will form, and that jet will float towards the collecting drum, which will be collected, which is also kept at a fixed distance. Similarly, flow rate also disturbed. If the flow rate is too high, drop, it will it will cause a droplet, and it will fall down just beneath the syringe pump or needle tip. If it is too low, it will just cause electrospraying, spraying instead of electrospraying. So optimize amount of polymer flow rate you need to use in order to get uniform polymer fiber. Similarly, solution viscosity is also an important factor. If a solution is less viscous, it will also get it will not we will not get the proper chain entanglement, and we will get electrospraying like we can see in these pictures. Furthermore, if the solution viscosity is too thick, then we will get beads instead of nanofiber, or we can get nanofiber but beaded one, which we don't want, of course. If we properly optimize the viscosity of the polymer solution, then we can get uniform nanofibers which are collected, which we can collect at the collector. Similarly, solvent also has an important role. If the solvent is too volatile, it will just evaporate quickly, and the fiber will dry during the flight towards the collecting drum. So in order to avoid that, which will also cause beads, in order to avoid that, we need to use solvent that can help us in generating uniform nanofibers. At times, we want to fabricate porous nanofibers in which there are pores on the surface of the fiber. Then we can use volatile solvent, but that too, for that we need to optimize the parameter thoroughly and properly. These are the applications of electrospun nanofiber. They have found potential application in applied sciences, tissue engineering, filtration media. Electrospun nanofiber have been vastly used in filtration media for removing of dyes from wastewater or industrial wastewater, we can say. Similarly, nowadays, electrospun nanofiber have been used as a face mask due to the COVID era. People started fabricating face masks from through electrospinning. Nanosensors, they have found potential application in nanosensor, as well as military protection clothing like biogases, absorption of gases on the surface of nanofiber, and cosmetic skin masks. It was expected that 2020 it will have 14 million product, but that figure must have increased by now. As I just mentioned, that due to COVID, people also started fabricating polymeric face masks. As these polymeric scaffold fabricated through electrospinning have interfibrous porosity, as well as they can absorb solvent or gases on their surface. So it was a good idea by the people who fabricated face masks through electrospinning. They have also found potential application in artificial blood vessel tissue engineering, drug delivery. As the topic of my presentation is tissue engineering, so I will further emphasis on the application of electrospun nanofiber in biomedical application. So they have found application in artificial blood vessel tissue engineering, drug delivery, functional textile, role in protecting protein, and enzyme immobilization. Numerous strategies have been adopted for the fabrication of wound dressing agent, which include blending, mixing of nanoparticle with polymeric solution, or drug core heat fabrication, encapsulation. Post-treatment, first you electrospun nanofiber, then you treated it attachment. First, in this method you fabricate electrospun nanofiber, and then you loaded the nanoparticle or attached the nanoparticle or drug on the surface of the electrospun nanofibers. So these strategies have been used for the fabrication of electrospun nanofiber and their further potential application in various fields. This is the first study which I am going to present right now. Is these are the purpose of the study to graph protein growth factor and drug on the surface of NHA. In fact, this surface immobilization of NHA, and then this NHA immobilized NHA will be encapsulated or entrapped in the polymer PLGA polymer matrix, and then in vivo studies will be performed or were performed. So in the first study, morphological effect of HA on the cell compatibility of electrospun NHA hybrid nanofiber scaffold. The purpose of this study was to find the difference or effect of shape of hydroxypeptide on the surface on the osteoblastic cells. PLGA, as we all know, is I will just give a brief introduction about PLGA. Biomaterial scientists know PLGA very well. Hydroxypeptide was synthesized in the lab, solvents and other material were used. PLG is a biodegradable, biocompatible polymer wound dressing, and it has found application in wound dressing, artificial blood vessel scaffold for new tissue growth. Hydroxypeptide is a component of it is considered to have structure and component similar to natural bone, biocompatible and bioactive, well-known implanting material, and used for bioceramic coating. It is also used as a bone filler material. So in this study, this is a CM micrograph of electrospun PLGA nanofibers. Here I want to mention that the hydroxypeptide we used was of two morphology. One was spherical and the other one was nanorod shaped, which will come later on. I will and also I will explain the reason why which one was better than the other one. So these are the SEM micrograph of the PLGA. This is the wet person solution used pristine PLGA fiber. This is the spherical SEM images of the spherical hydroxypeptide and PLGA composite. And this is the nanorod SEM micrograph of nanorod hydroxypeptide PLGA nanofiber. As we can see that in all the micrograph, the morphology of the nanofiber was smooth and uniform. These are the TEM images of the nanorod hydroxypeptide and spherical hydroxypeptide. You can clearly see that the nanorod hydroxypeptide were rod shaped and uniformly dispersed, and the spherical were in spherical shape. This is the TEM images of the electrospun nanofiber of nanorod incorporated into a PLGA polymer matrix, and this is the spherical hydroxypeptide which was incorporated in the PLGA matrix. This is the ADS images which shows the quantitative or qualitative analysis, you can say, showing calcium and oxygen and phosphorus deposition or confirmation that nanorod and spherical were successfully incorporated into the PLA polymer matrix. This is the FTIR spectra, which also confirm that hydroxypeptide, both spherical and nanorod were successfully incorporated. This is the ESCA survey scan spectra, which shows the calcium peak and phosphorus peak, which was also a sign or a confirmation that the spherical and nanorod hydroxypeptide were successfully incorporated into those. Here, it was the qualitative analysis, which also showed that the nanorods were successfully incorporated in their respective nanofibers. After confirmation, we performed in vitro study. We cultured osteoblastic cells, which are bone-forming cells, and all the scaffold. This is one A, B, and C are 1-day results, and D, E, and F are 3-day results, which shows that the osteoblastic cells was cultured and the cells adhered on the surface of on the surface of the nanofiber scaffold, both on the pristine, spherical and nanorod. Whereas we can see more cells adhere and proliferated on the spherical and nanorod compared to the pristine PLGA nanofiber matrix. But furthermore, in this we can see that nanorod showed better or provided native environment compared to the spherical, although it is a very minor change, but still it's a change. Better environment to the cells. That's why osteoblastic cell proliferated more on the nanorod hydroxypeptide PLGA nanofiber matrix compared to spherical and pristine nanofiber. This was further confirmed by Beldu analysis, which showed that more cells proliferated on NHA, PLGA compared to SHA and PLGA nanofiber scaffold. Then we perform alizarin red staining. It's the staining of for determination of osteogenesis, which is a bone formation process. So we can see that the more reddish color showed that NHA provided more native environment, or the we can say osteoblastic cells proliferated and found native environment, home-like environment, and they proliferated and then underwent osteogenesis process, which is a bone forming process compared to SHA and PLJ. Similarly, one COSA assay we performed, which is a calcium deposition assay. It also confirmed that NHA, PLGA showed more confirmed calcium deposition compared to the SHA and PLGA nanofiber. Then we also perform ICP release experiment, in which showed that NHA showed more release compared to the PLGA. This was a schematic sketch. The reason or the purpose why we thought that NHA showed better or provided net environment to the cells. This was our assumption of the study, which showed that here we can see that phosphorus is on the outer side and calcium, and in the nanorod calcium is on the outer side. So we thought that biological molecules are negatively charged particles, so we can get a positive and negative interaction between them, and that's why it provided a more home-like environment. NHA provided home-like environment to the cell, osteoblastic cells, compared to the SHA. So we fabricated NHA, SHA, and then we incorporated into the PLGA nanofiber matrix. Then we performed confirmatory test, and later on we performed in vitro study, cell culture study, which showed that SHA compared to SHA, NHA provided more feasible and native environment to the cell, and cell proliferated on the scaffold compared to the SHA. In the second study, we loaded insulin on the surface of NHA and incorporated in the PLG nanofiber matrix. This was the scheme or the theme of the study. First, as insulin was immobilized on the surface of NHA, and then that NHA was incorporated into the PLG polymer matrix, and we were thinking that that insulin will interact with the receptors on the cells, and that will activate this pathway for enhancing osteoblastic cell growth. As we know, insulin is also a growth factor. Similar, this is a well-known protein. It helps in metabolism, a well-known growth factor, and regulating sugar body in the sugar level in the body, which we all know. This is the mechanism of the cells, but I will not go into detail of this mechanism. First, how we immobilize this scheme shows that the first succinic acid was grafted using, it has carboxylic group, so one terminal was linked with OH and the other was left free. In the second step, amide bond formation occurred due to NH2 and carboxylic acid. And this shows the successful sketch shows the successful grafting of insulin on the surface of hydroxyapatite. And then we used this hydroxyapatite and you blended it with the polymer PLJ polymer solution and subjected to electrospinning in order to get smooth and uniform fiber. These are the images of the PLGA, NHA PLGA and insulin grafted NHA PLGA fiber scaffold. As you can see that before grafting hydroxyapatite were you can say agglomerated are not well distributed, whereas in this picture you can see clearly distributed. Then this image shows that it has agglomeration, but the nanorods were incorporated in the PLJ polymer matrix, and this is the insulin grafted nanorod in the PLJ nanofiber matrix. FTIR confirmed the successful grafting by the appearance of the amide bonds. Then we perform ASCA scan spectra, which is a quantitative and qualitative analysis, which shows the quantity and quality of the material used in certain study, and then we perform this ASCA. So it gives a brief and very detailed characterization results. So from that that also second that insulin was successfully immobilized on the surface of the nanohydroxyapatite, and then insulin grafted NHA was immersed in the was immersed in the PLG nanofiber matrix. This is the SEM images of the osteoblastic cell culture on the surface of the nanofiber. You can see that cells were adhered and later on they proliferated, but more cells were proliferated on the insulin grafted NHA PLJ compared to the NHA PLJ. The basic reason is due to the presence of insulin, which, as I mentioned earlier, as it is a growth factor. It also enhances the growth of the cells apart from regulating the sugar level of the body. So video analysis we performed, which showed that more cell proliferated on insulin grafted NHA PLJ compared to the NHA and PLJ nanofiber matrix. Then we perform confocal study, which also showed that the cells proliferated and they had actin cytoskeleton formation too, and more cells were proliferated on insulin grafted NHA PLGA compared to non-grafted and pristine PLGA nanofibers. Alizanin red staining we performed, which also confirmed, and one for alizanin red staining, one for assay both confirmed that more cell proliferated on the and later on underwent osteogenesis on the insulin grafted NHA PLJ compared to the NHA and pristine PLJ nanofibers. This is a conclusion that insulin was successfully grafted, then it was successfully immersed and incorporated into PLJ nanofiber matrix, and after culturing osteoblastic cells, more cells were proliferated on the insulin grafted NHA compared to the PLGA nanofiber pristine PLG nanofiber matrix. Then we used BMP2, which is also a famous bone morphogenic protein, which is a growth factor. For ligand receptor, we targeted the ligand receptor interaction for targeted delivery of BMP2 to the osteoblastic cells. This is the this scheme depicts the grafting of BMP2 on the surface of hydroxyapatite. In the first step, L-glutamic acid was immobilized. It has carboxylic acid on both the ends, so one was linked and the other was left free. Then the L-glutamic acid modified NHA was added to the immersed stirred with the PLG solution and was subjected to electrospinning for generation of smooth and uniform nanofiber. Once the nanofiber were fabricated, then we used BMP2 to link with the carboxylic acid, the free terminal carboxylic acid of the L-glutamic acid. So this is again HMMAG is showing uniform morphology, beadless morphology, and TM images of the and before grafted and after grafted, and if TEM images of the nanofiber having NHA and grafted, non-grafted and grafted NHA. Again, we confirmed amide 1 and amide 2 bond confirmed that BMP2 was successfully grafted on the surface of NHA. SCA survey scan spectra also confirmed the successful presence and successful grafting of NA insulin on the surface of NHA, which was found in the PLG nanofiber matrix. This result shows the cell culture studies, in vitro analysis, like cell were adhered on all the scaffold. However, most cells were adhered and later on proliferated on the BMP2 grafted PLGA nanofiber matrix compared to the non-grafted in PLG nanofiber matrix. Build USA also confirmed the same, that more cell proliferated on the BMP2 grafted compared to the counterparts. Later on, we perform actin cytoskeleton staining. In this, we can see that more cell proliferated on the BMP2 grafted cells compared to the non-grafted and pristine PLG nanofibers. Similarly, alizarin rate staining also confirmed that more cell-driven osteogenesis, which is a bond again, which is a bond for formation process compared to the non-grafted and pristine nanofiber matrix. One COSA assay also confirmed the same, that more bond nodules were formed on the BMP2 grafted scaffold compared to non-grafted and pristine PLG nanofiber matrix. So in this study, BMP2 was successfully grafted on NHA, which was already immersed or incorporated into PLG nanofiber matrix, and then it was thoroughly, after characterization, was subjected to in vitro study, which showed that more cells proliferated and underwent osteogenesis on the BMP2 grafted scaffold compared to the non-grafted and pristine PLG nanofiber scaffold. In this work, we used palmidronic acid and grafted it on the. Okay, I will wind up in 5 minutes. No, you're welcome. So in this study, we used palmidronic acid, which suppresses osteoclastic activity. This shows why we were using palmidronic acid on the NHA. NHA helps osteoblastic cell formation, and palmidronic acid here, P suppresses osteoclastic cell activity. That means one is enhancing bone formation and the other is suppressing bone resorption. So palmidronic acid suppress bone resorption. That was the main objective of using palmidronic acid. This scheme shows the grafting of the palmidronic acid on the surface of NHA. These are the SEM images and TEM images of the pristine PLGA, unmodified and modified NHA incorporated in the PLGA nanofiber matrix, and these are the unmodified, modified NHA using with palmidronic acid, and these are the unmodified and modified NHA incorporated in the PLG nanofiber matrix. These are the FTIR and survey spectra confirming the successful grafting of palmidronic acid on NHA and incorporation of that NHA, palmidronic acid grafted NHA in a PLG nanofiber matrix. This shows that more cells were adherent and proliferate on the scaffold. However, more or almost, you can say, same were proliferated and unmodified and modified NHA due to the presence of hydroxyapatite. This shows the alizarin staining also confirmed that almost same amount was as palmidronic acid, only suppresses osteoclastic cells activity. So same amount, almost same amount were both underwent almost same amount of osteogenesis. So for osteoclastic cells, first we differentiated macrophage into osteoclastic cells. Multinucleated, when we got multinucleated cells, then we confirmed that these are osteoclastic. We perform MTT assay, which also showed that palmidronic acid killed, or you can say suppresses osteoclastic cells activity. Live and dead cell staining also showed that palmidronic acid has reduced osteoclastic cells activity. So in this study, we aimed that osteoclastic cells activity will be suppressed by palmidronic acid, and hydroxyapatite will enhance osteoblastic cells activity, which was confirmed by various spectroscopic and microscopic technique. And then more cells showed that, in vitro analysis showed that osteoblastic cells activity was enhanced by the presence of HA, and the palmidronic acid suppressed osteoclastic cells activity, which are bone resorbing cells. And that's all from my side. Thank you. If you have any questions.
All right, thank you, Dr. Adnan. So, yeah, Dr. Adnan showed us 4 of his research. It's quite difficult to summarize, Dr. Adnan, but I will try. Basically, Dr. Adnan tried to make a hydroxyapatite-based electrospinning nanofiber for the delivery of insulin, and then for the tissue bone engineering, and the last one, I think, to stimulate osteoblastic cell activity, or anyway, there is many application of electrospinning nanofiber. And then not only that, we can also use electrospinning nanofiber for the cosmetic application, and then for military protective clothing, and many other ways. And in biomedical application itself, it can be used to make artificial blood vessel. Now come to the Q&A session. I would like again to invite you if there is any question from the audience or from the meeting Zoom maybe. No one? All right. Dr. Adnan, I have one question. So,
yes, please.
Yeah. Electrospinning nanofiber actually a part or branch of drug delivery system that I haven't touched at all in my master and PhD degree. So actually I'm quite wondering, is there any way to make nanofiber in the laboratory scale? I mean, like nanoparticle, we can use simple method or conventional method. But electrospinning nanofiber without the electrospinning or the instrument itself is quite difficult to make it. So do you think, is there any way that we can use it in a very simple way, maybe?
There are some, you can say, if you improvised it, you can use you can get electrosprayed material, but not electrospun material, because for that you need the electrospinning instrument, which you can use. But if you improvised on certain other material, then you can fabricate that. Maybe they might not be the nanofiber. You can get microfiber, or you can get coating, spray coating from that other, if you do little bit of improvisation, which we are researcher always do to get or fabricate something. But for, in short, for electrospun nanofiber, you need an electrospinning instrument.
Last questions about the application of nanofiber for artificial blood. So can you explain more about the clinical application for that? So if we use nanofiber to make artificial blood vessels, so how long the durability or the sustainability?
It depends on the polymer which you use. For example, for polymer, there are 3 monomer ratio, lactide to glycolide. So if you change it from 85 to 15 ratio to 50-50 or 25-75, that will reduce the duration of the PLG nanofiber, and after certain time it will degrade. For example, it has 3 monomer ratio. I use 85 to 15, which has duration of almost 6 months. But if I use 75, it will have a biodegradability duration of 3 months. And if I use 50, it will have biodegradation, it will get biodegraded in within 1 month. So it depends on the polymer which you use. Either the polymer is first biodegradable, and if it is biodegradable, how long it will take to get biodegraded. If it is not biodegradable, then what is the biomedical importance or the biocompatibility aspect of that polymer? So you have to counter all these things to use it for certain applications.
Topic. I think if there is no any more question, this is the end of Dr. Adnan session. So please join me to give a big round of applause to Dr. Adnan. And then Dr. Adnan, we will give you online certificates. So I will invite Prof. Marianti, maybe to, oh no. Dr. Yulia, please join me in the stage to give the certificate.
Hello, Dr. Adnan. Assalamualaikum.
Hello. Walaikum Assalam.
Yeah, we are very happy that you can present your topic today, and it's really honor for us to give you this e-certificate on behalf of Hasanuddin University. So thank you very much for joining our conference today. Thank you.
Thank you so much for inviting me.
Yeah, so probably you can join us in the next year or so, yeah,
Inshallah.
for another conference.
I hope so.
Okay, Dr. Adnan, please come to Makassar, Indonesia. We will welcome you
Of
to
course.
here. Okay.
Thank you. Of course.
All right. Okay. Thank you. So.
We would like to ask Apotheker Yulia Yusrini Jabir to come to the stage again to give certificate to our moderator for this session, Apotheker Nur Hasni Hasan.
Okay, I think that's for the session, my sessions. Again, I thank you for all your attention to this, and thank you for Dr. Adnan and Dr. Tommy. I think that's all. Thank you very much.
Now we will have break session for lunch and pray until 1:15 p.m. We would like to inform you that during the break session, there will be poster presentation outside of this room. You may look forward to the poster outside of this room, and also please enjoy the meal that we serve. Thank you very much.
gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. As it was. You know it's not the same. Holding me back, gravity's holding me back. I want you to hold out the palm of your hand. Why don't we leave it at that? Nothing to say, and everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. As it was. You know it's not the same. Holding me back, gravity's holding me back. I want you to hold out the palm of your hand. Why don't we leave it at that? Nothing to say, and everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. As it was. You know it's not the same. Holding me back, gravity's holding me back. I want you to hold out the palm of your hand. Why don't we leave it at that? Nothing to say, and everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. As it was. You know it's not the same. Holding me back, gravity's holding me back. I want you to hold out the palm of your hand. Why don't we leave it at that? Nothing to say, and everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. say when everything gets in the way? Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. to say when everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. As it was. You know it's not the same. Holding me back, gravity's holding me back. I want you to hold out the palm of your hand. Why don't we leave it at that? Nothing to say when everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was. As it was. As it was. You know it's not the same. Holding me back, gravity's holding me back. I want you to hold out the palm of your hand. Why don't we leave it at that? Nothing to say when everything gets in the way. Seems you cannot be replaced, and I'm the one who'll stay. Oh, in this world, it's just us. You know it's not the same as it was. In this world, it's just us. You know it's not the same as it was.
is rising. Take a look at the reason. Can you see it's shining bright? The light is warm you up right to your skin. Can you stop complaining? You don't need to cry. You are not the only one who faced the life with your scream.
It doesn't matter when you lost a call day, you will find a way to make it your way. Even if the skies get dark and gray, you won't get in our way. It doesn't matter when they're talking all day, they ain't even better than a soul stay. We can fight together, don't give up and make it time to wake up. No more tears drop on the floor, get rid of sorrow. We'll go run the world and greet tomorrow. Wake up, no more tears drop on the floor, get rid of sorrow. We'll go run the world and greet tomorrow.
Life is about dreaming. Living without a dream is a mistake. It is not easy to reach a star far from the eye, but reality keeps us away from our expectations. Success is a choice. Everyone has equal opportunity. The problem is, what is your choice? Go ask yourself.
Run the world and greet tomorrow.
Our vision is to be a center of excellence in human development, science, technology, art and culture in the field of pharmacy based on the Indonesian maritime culture.
Our mission in the Faculty of Pharmacy is developing science, technology, art, and culture in the field of pharmacy through excellent research to produce innovative products and ideas.
Providing facilities and infrastructure to support a representative learning process to create a conducive academic atmosphere so as to produce ethical, proactive, and innovative learners.
Implementing and disseminating science, technology, art and culture in the field of pharmacy for the benefit and welfare of the community.
Credible, transparent, accountable, responsible, and fair governance system.
In line with the faculty mission to support high standard of education in pharmacy and pharmaceutical sciences and technology, Faculty of Pharmacy, Hasanuddin University conducts bachelor program, magister program, doctoral program, and a professional apothecary program to support effective teaching, creative learning, and dynamic research environment. Faculty of Pharmacy, Hasanuddin University, commits to give the best experience for the students in terms of learning process, facilities, and service. With the competence-based curriculum, our lecturers engage students on discussion, fieldwork collaboration, cooperative learning, problem-based learning, and other student-centered learning methods. Hasanuddin University also provides a learning management system called Sikola, Sistem Kelola Pembelajaran. This platform facilitates online learning as well as enables lecturers and students to interact through numerous features available, using affordable and user-friendly features like direct chat and online group discussion to help the process of transferring and receiving knowledge to be more efficient. Faculty of Pharmacy, Hasanuddin University, also prepares students to be leaders in addressing and solving any challenges in the pharmacy issues with high understanding on ethical and social implications of their knowledge as pharmacists to bring prosperity and a good life for patients and community. Faculty of Pharmacy, Hasanuddin University, provides a number of learning laboratories which allow students to learn and practice laboratory skills and procedures in simulated setting. There are 8 learning laboratories or research groups at the Faculty of Pharmacy, Hasanuddin University, namely Pharmaceutics and Technology Pharmacy, Pharmaceutical Microbiology, Clinical Pharmacy, Pharmaceutical Chemistry, Pharmacognosy, Phytochemistry, Biopharmacy, and Pharmacology and Toxicology Laboratory. Faculty of Pharmacy also has an integrated research laboratory equipped with cutting-edge technology instruments called Biopharmaca. This lab was launched on 2012 by the Minister of Education and Culture at that time, Professor Dr. Insinyur Muhammad Nuh DEA. Aside from providing variety of tests on clinical and pharmaceutical research purposes, Biopharmaca also offers a wide variety of training for those who need knowledge and skills in controlling the quality of natural and synthetic-based drug candidates, foods, and cosmetics.
Selamat datang di Universitas Hasanuddin. Universitas Hasanuddin merupakan salah satu universitas terbaik di Indonesia. Ditunjang dengan fasilitas unggulan dan dukungan teknologi informasi yang modern, seperti dengan hadirnya e-library atau perpustakaan digital yang menyediakan berbagai literasi dan informasi secara digital dan online. Terdapat juga pusat pelatihan bahasa yang dapat membantu para mahasiswa mengembangkan kemampuan bahasa asing mereka. Kampus ini menjadi miniatur peradaban Indonesia dan dunia, tempat memahami toleransi keberagaman melalui interaksi antar budaya.
Dengan hadirnya mereka di sini, mereka bisa belajar tentang budaya kita. Begitu pula sebaliknya, kita bisa mengenal budaya bangsa lain yang ada di tengah-tengah kita.
Tidak hanya itu, Universitas Hasanuddin menyediakan fasilitas olahraga, seni, dan budaya yang diperuntukkan bagi mahasiswa dan juga masyarakat.
Di Unhas, kita tidak hanya bisa berprestasi dalam mata pelajaran, namun kita juga bisa berprestasi dalam cabang olahraga renang seperti hobi saya ini.
Dengan ini dinyatakan dibuka dan terbuka untuk umum.
graduate from Universitas Hasanuddin for his bachelor and professional degree. And then she continued her study in James Cook University, Australia for his master and doctoral program. To Apotheker Yulia, please.
Thank you, Cindy. Before I start, I would like to invite Dr. Helmut Schlager to the stage. Yeah, and I'll introduce you a little bit about Dr. Helmut. So Dr. Helmut, born in Germany, but the nationality is Austrian. Yeah, and then for his professional career since 1999, he's already joining the Bavarian Chamber of Pharmacists in Munich. And then since 1999, he's the first reverend of the president of pharmaceutical care. And since 2008, he's the managing director of WIPIC, Scientific Institute for Prevention in the Healthcare. And I think Dr. Helmut will talk about a little bit of glycemia, and that's related to his task in director of WIPIC. And since 2005, his specialization in the field of homeopathy and naturopathy, nutritional counseling, prevention, and health promotion. So without further ado, I would like us to welcome Dr. Helmut Schlager. Thank you very much. Time is yours.
Selamat siang. Hello, everybody. Dear Dean, Professor Marianti Mangau, dear Chairman of the Organizing Committee, Dr. Rahim, dear Vice Deans, thank you very much for the invitation, and Dr. Julia, thank you very much for your kind introduction. Ladies and gentlemen, dear colleagues, it's really a great pleasure for me being invited to come to you to Makassar and to speak to you about the preventive care by community pharmacists in Germany. The title of my lecture, Prevention of Type 2 Diabetes, which is indeed a major challenge to the 21st century, I would like to present to you the results of our diabetes prevention trial named Glycemia 2.0 and how we have been trying and still try to transfer our scientific work into the community pharmacists' practice. Okay. Assistance for the skipping of the slides. Here it's correct, there it's not correct. Meanwhile, as Dr. Julia told you, my name is Helmut Schlager. I work for the Bavarian Chamber of Pharmacists, which is the professional presentation for around about 16,000 pharmacists living in Bavaria. We have a little institute called Scientific Institute for the Prevention and Healthcare, and I'm the managing director of this institute. Now it would be nice if you could see the next slide. The next slide will show, oh yeah, okay, that's it. Thank you very much. Here you can see our house in Munich, the Bavarian Chamber of Pharmacists. And what you can see else in this slide is the policy of our institute, research and development of new prevention ideas, projects, and their implementation into practice. Development and implementation of courses for the further education of experts working in the field of prevention. Establishing networks of active partners in the health, sector to intensify cooperation in the field of prevention and also very important, the raising of awareness of the public, of society, and most of all of political decision makers for the future-oriented field of prevention. Next slide, please. In the first slide, you have three names, and I would like to present to you the three persons which are the scientific core team of our study. There are still some problems with the slides, but I can continue to talk. The first was Christina Friedland. She's former professor for molecular and clinical pharmacy at the Friedrich Alexander University Erlangen-Nürnberg, today University of Mainz. The second, Professor Friedland was the PhD supervisor for Katja Brax, our 4 years hard and successful working PhD student, and she did most of the work, and she was the clinical research monitor who worked with the patients and who worked with the pharmacies together. And the third one is me. Yeah, you can see me live. I had the sometimes strenuous role of the clinical research manager. Well, maybe 1 minute more. It's not so important. This is the first slide. You can see three names: Katja Brax, Professor Christina Friedland, and maybe we can continue with the slides now. Some short facts about my home country and my federal state, Bavaria. With a population of 83 million inhabitants, yeah, you can see the three of us during a Zoom meeting, Katja Brax at the right, the PhD student, in the middle, Professor Friedland and me. So next slide, please. Yes, that's it, great, thank you. Okay, with a population of 83 million people, Germany is the highest populated country in the European Union. We have 22 departments of pharmacy. You can study pharmacy in 22 universities. We have around about 68,800 pharmacists working in Germany, and 53,300 of them work in community pharmacies. The study which I present to you was realized in Bavaria, which has 30 million inhabitants and around about 3,000 community pharmacists. Next slide, please. So now let's really start. What's the structure of my lecture today? What will we talk about in the round about next 40 minutes? First, I will show you some statistics and basics concerning the diabetes disease. We talk about the motivation for our scientific work, about the aims of the study, the implementation into practice, and then, of course, the most important thing, what did we find out? What did we find out? We're going to talk about the outcomes, and in the end, we can try to have a look in the future. Let's have a short repetition, next slide please, into prevention. We talk about primary, and please to the end of the, no, further, next, stop, no, back, thank you, yeah. We talk about primary, secondary and tertiary prevention. Pharmacists can contribute to prevention in settings like in kindergarten or in school or in workplaces. But I strongly believe that our best setting as pharmacists is the community pharmacy, where we can work in the field of prevention in behavior. Pharmacists can help the development can help to prevent the development or the onset of diseases. That's primary prevention. They work in the field of early detection, they offer screening, and they give advice, consulting, and guidance to the patients. That's secondary prevention. And concerning the tertiary prevention, which is our main focus as pharmacists, we help to prevent complications, consequential damages, and the progression of diseases. Next slide, please. And once more. Yes, thank you. Worldwide, we have so many problems and we have so many diseases. There's actually so much to do. So why did we concentrate on diabetes? Please let me show you some numbers, data, and facts from the International Diabetes Federation. On this slide, you can see the prevalence of diabetes mellitus worldwide during our study in 2019 for the 20 to 17-9 aged old people, so the adults. The majority of patients are affected by type 2 diabetes, which is associated with obesity and lack of exercise. By the way, lack of exercise. Now we stop the presentation and I would like to ask you if you could please stand up now, everybody.
Ayo,
stand up
berdiri,
and
berdiri,
get up.
stand up.
We will have to do a short exercise. Everybody has had a delicious meal and you all know about the postprandial gap. And so we will fight against the postprandial gap and you just have to act like I do. So let's start, some music.
Music, please. Ayo goyang.
I have one last exercise and we can do it while sitting. It's an exercise to get your spine moving. You sit like me, exactly like this, and do like this. Then you start like this. Very quick, feel your spine. It's moving. Yeah, it's a good exercise while sitting in front of a Zoom meeting or something like that. Thank you. That's it. Okay, thank you very much. Dear colleagues, you will probably be more interested in the data for your region, so please let's go to the next slide. You can see the number, data and facts, and the number of people with diabetes worldwide on the left side, and especially interesting for you on the right side for the Western Pacific region. Please, let's go to the next slide. The International Diabetes Federation publishes something called like IDF Atlas, and this reports a continued global increase of diabetes prevalence, confirming diabetes as a significant global challenge to the health and the well-being of individuals, of families and societies. Data for the Western Pacific show that 1 in 8 adults, round about 206 million, are living with diabetes. The number of adults with undiagnosed diabetes is expected to increase the number of adults with diabetes is expected to increase to 238 million by 2030 and even to 260 million by 2045. Over 1 in 2 adults living with diabetes are undiagnosed. There were around about 2.3 million deaths caused by diabetes during the last year. And also, money is an important thing. Around about 241 billion US dollar were spent on diabetes during the last year. Therefore, the prevention of type 2 diabetes is a major challenge for the 21st century. Not only in Germany, but also in Indonesia. In Germany, we have approximately 9.5 million people between the ages of 20 and 79 that suffer from diabetes mellitus, which puts Germany worldwide at the 8th place and in the 1st place in Europe. Indonesia, as you all know, has 275 million inhabitants, and Professor Mangau, she told me that 19.5 million people live in Indonesia with diabetes, and I learned from Burkhard Kleusser yesterday that another around about 14 million people in Indonesia are undiagnosed. So we have a lot to do. In Germany, the need of a population-wide diabetes prevention was already established in 2011 with a political declaration on the prevention of non-communicable diseases. But as we all know, declaration are the one thing, action is really another thing. Therefore, we still need programs that contribute to a more effective prevention. On the one hand, because of ethical reasons, pharmacists really do want to help their patients, and we have a lot of severe micro and macrovascular complications. The next slide, please. And yes, next, please. Stop. Yeah, great. Thank you. 1/3 of the patients with diabetes suffer from retinopathy, which leads to blindness. 50% suffer from nephropathy, which causes renal damage to the kidneys. The risk of renal insufficiency is 10 times higher than for non-sick persons. 1/3 develop a neuropathy, which can cause heart rhythm disorders, silent ischemias, and erectile dysfunction. Diabetes leads to death caused by cardiovascular diseases for 1/3, up to around about 50% of the patients, and one of 8 patients suffer from the so-called diabetic foot syndrome. We have 2 amputations worldwide per minute. That means during my lecture, 90 amputation. Moreover, we must act not only because of ethical reasons, but also for financial reasons. We have very high diabetes-related health costs. Diabetes-related health expenditure is nowadays estimated to account for 11.5% of the total global healthcare budget. As 784 million people are projected to have diabetes in 2045, it is really essential that more efforts are made to implement type 2 diabetes prevention plans and to introduce more cost-effective ways to manage the different types of diabetes. So, next slide, please. the aim of our work was to care for the patients as well as possible that they can achieve good control of their blood glucose levels. As we have seen, type 2 diabetes patients have a high risk for micro and macrovascular complications. Hereby, a poor glycemic control leads to progression of disease, hospitalization, and reduced life expectancy. As you can see in this slide, the data are basing on a meta-analysis regarding the effectiveness of disease management programs for improving diabetes care. And 1% reduction of the hemoglobin A1C level has an impact on the risk for microvascular complications of minus 37%, and on the risk for diabetes-associated mortality of minus 21% in general. Already a 0.5% reduction of the value is clinical relevant. Indeed, we can see how important an effective reduction of the blood sugar level really is. So it was our aim during our study to effectively improve glycemic control and to reduce the risk complications during our study. Next slide, please. Let's talk about policies and our reflections regarding the development of preventive care. In Germany, the Federal Union of German Associations for Pharmacists published the so-called Professional Perspective Paper Pharmacy 2030, dealing with a legal catalog of reimbursed public care services. So what do pharmacists can offer, and it must be paid for. That's the important thing. As this catalog also deals with preventive care, it was substantial for our work. As you can see on the right side, please go on. Go on further, please. Further. Yes, thank you. So as you can see on the right side, concerning the latest studies, there are not many studies. There's not much evidence. Thank you. Thank you. There's not much any evidence regarding community pharmacists' interventions to improve glycemic control of diabetes in Germany. Large randomized controlled trials for community pharmacists are rare. We could only identify four studies in Europe and even none in Germany. Therefore, Glycemia 2.0 was developed to examine whether intensive pharmacist-delivered care in community pharmacies can effectively improve glycemic control and reduce the risk of complications. Next slide, please. Oh, is it me or is it you? I do it? Wait a second. No, this goes back. Okay, forward, just a second. Now, wait. Now we've got it. Actually, we have already developed a structured program based on our first glycemia trial from 2012 until 2014 that was dealing with primary prevention. We worked with groups of people who were at risk of becoming diabetic patients. After the successful evaluation of this first program, there should be the possibility to provide an effective program now regarding secondary and tertiary prevention to community pharmacists in Germany. In 2016, we then concentrated on these aspects of prevention, set our focus again on lifestyle change but also on medication review and the adherence of the patients. The objective of the study was to assess if this intensive prevention and pharmaceutical care has an impact on HbA1c values of type 2 diabetic patients. Oops. Yeah, that's it. The study protocol has already been presented here in Makassar 5 years ago at the International Conference of Interprofessional Education in September 2017. And so now it's my pleasure to tell you something about the results of this study. Let's have first a look at the process flow. The study was a randomized and controlled trial in 26 community pharmacies in Bavaria. The pharmacists supported the participants of the intervention group for 1 year in a protocol-defined lifestyle change and medication review. According to European guidelines and other studies, the intervention was implemented in 3 personal counseling sessions at baseline after 6 and 12 months. You can see the timetable. You can see 2000. Doesn't matter, the pointer does not work. Okay, once again, 3 personal counseling sessions at baseline after 6 and 12 months, 6 educational group meetings, 4 in the first half of the year and another 2 in the second half of the year, and monthly telephone calls. The control group only received written material and usual care driven by the pharmacists. In this slide, you can see the materials for recruitment. The pharmacists were given flyers, posters, schedules, appointment cards for free measurement of A1C values, lists of interested participants, participant information, declarations of consent, also a letter of information for the physicians. For the organization, legal notices, letter of remembrance for the first assessment, appointment cards, calendar of events, and list of pseudonymization. As mentioned before, we had these 6 group-based lectures. First, the title and then the agenda. We had prevention instead of leaning back, diabetes and prevention basics, individual aims to adopt a healthy lifestyle, and after this first lecture, we included a 30 minutes walk with the patients after the lecture. And the patients, they were given pedometers, so like step counting devices to count their steps, because we know this is very motivating for the patient to improve their walking and their motion. Second, moving through everyday life. Agenda, everything about movement and physical exercise. Third, getting a grip on my therapy, so my therapy under control. Knowledge transfer about therapy, anti-diabetics, the risk of hypoglycemia, consequential or secondary diseases. Fourth, my diet matters. Healthy, well-balanced diet, strategies to reach the target weight, and tips and tricks for the patients. So this was the first 6 months, and in the second half of the year we had 2 further lectures, Courage for a Change, a first summary draw for the patients, further behavior change, and another 30 minutes group walk. And last but not least, we had the lecture, It's Worth Keeping Up, how to achieve my goals, maintain the process and the success, and relapse prevention. And for all the lectures, we developed information sheets, we developed manuscripts with additional notes and a summary handout for the participants. So let us now talk about our inclusion criteria. Of course, the participants had to have a diabetes disease and a hemoglobin A1C value of 7 or more. Furthermore, a body mass index of at least 25, age over 18 years, at least one oral anti-diabetic drug, and altogether at least 3 drugs on the long run. Lots of studies show that diabetes-associated mortality for over 70-year-old people is especially increased with very high and also low A1C levels. There's really a kind of Y-shaped distribution. Values higher than 8% and less than 6%. So patients with values of more than 8% have a very high benefit of the program. That's actually the reason why we wanted to include only patients with values for more than 8%, but because of recruitment problems in our pharmacies, we had to lower our expectations and had to downgrade our inclusion criteria to the 7% limit, because it's really hard to find enough patients willing to take part in a study like this. So who could not take part in the study? We talk about the exclusion criteria, persons with treatment exclusively with insulin, cardiovascular events in the past, cancer diseases or another severe disease, and pregnancy. So now let's have a look at the outcomes. As primary outcomes, we had chosen the hemoglobin A1C level. Besides from that, the assessment included for the secondary outcomes fasting blood glucose, weight, and blood pressure. Questionnaires have been chosen to assess physical activity, quality of life, and the adherence. Furthermore, a data entry form was used, including data for the economic evaluation in the end of the study. The quantitative determination of A1C level was done at the point of care pharmacy, that means directly in the pharmacy, by photometric measurement with Abbott-Affinion analyzers and test cartridges containing integrated sample collection devices and all necessary reagents for the single test. The big advantage of the analyzer is that there is no need to send patients to a laboratory or spend time tracking down their results. So the Affinion analyzer is a compact multi-assay analyzer and provides valuable data near patient data directly in the pharmacy. And this was very good to have an effective way of measuring the A1C levels. So a kind of summary for the study design. According to the study design, the intervention group received individual counseling, an agreement on specification on individual aims to adopt a healthy lifestyle, a medication review consisting in detection of drug-related problems, transfer of information to the physicians in charge, and personal medication lists. Everything was assisted by the university, by our PhD student Katja, who did all of the clinical monitoring. 6 lectures and 2 times 30 minutes physical activity included walking, and the step counts by pedometers, and the regular telephone calls, 1 per month. let's come to the study participants' characteristics. Here on this next two slides, you can see the participants' characteristics. If you are interested in this data, we can maybe talk about it in the discussion at the end of my lecture. Now let's come to the most important part of the presentation, the results. Wait, just go back. Yeah. As you can see in this slide, 26 pharmacies managed to recruit altogether 198 study participants, 94 of them in the control group and 104 of them in the intervention group. During the study period, 12 in the control and 24 in the intervention group withdraw from the study, resulting in a dropout rate from around about 18%. A total of 86 participants of the control group and 96 participants of the intervention group were included in the analysis. In the next few slides, I would just like to show you the secondary endpoints, and maybe we can talk about them in the discussion at the end of my lecture. So we were looking at the different characteristics of the participants. We were looking at additional laboratory endpoints, at physical activity, at the quality of life, of course, and all about adherence, medication, and drug-related problems. I just want to point out the secondary endpoint concerning weight reduction and body mass index. The intervention participants reduced their weight from a median of 95.65 kilogram to a value of 91.3 kilogram. And in contrast to the control group, the intervention group managed a slightly greater change of 1.65 kilogram compared to 1.1 kilogram. In addition, it was evaluated how many participants were able to reduce their weight by at least 5% of their initial weight. This procedure was in line with the national guidance, the national guideline for the treatment of type 2 diabetes, which recommends a weight reduction of at least 5% for a body mass index of at least 27. The evaluation of this secondary endpoint showed that this was true for 7 subjects in the control and 21 subjects in the intervention groups, which means more than 25%. In a subgroup analysis, a statistically significant correlation was furthermore found between the A1C value reduction and the weight reduction. Even 10%, you can see it in the right, down the green part, even 10% of the intervention participants of the final survey were able to finish the study at normal weight. Such a development was not observed in the control group. But now we come to the most important slide that reveals the results for the primary endpoint. The control group started at baseline, the time of the first assessment, with a median A1C level of 7.9%. The intervention group showed a minimal higher value of 8%. And the participants of the control group, they managed to reduce their value to 7.6%, whereas the intervention group reached a significant better reduction to 7.3%. The results of the linear mixed effects model showed an adjusted change of minus 0.2% in the control group and minus 0.9% in the intervention group, and we had a p-value of 0.0001, so statistically high significant. The difference between the groups, the effect from the first to the third assessment presented at adjusted effect size was 0.7 and therefore highly statistically significant. As you can further see in this slide, the massive reduction of the A1C values in the control group could be stabilized in the second half of the year. So the adjusted effect size reveals the difference between intervention and control groups and refers to the effect from the first to the third assessment as a result of the linear mixed effect model. So this is the interaction effect. And one could say that the pharmacies had reduced the values for round about 1%, but because of the Hawthorne effect. I don't know if you have heard of the Hawthorne effect. This is a type of reactivity in which individuals modify an aspect of their behavior in response of their awareness of being observed. So in response of their awareness of taking part in a study. A subgroup analysis with a diagnosis not more than 10 years, they even showed a median change of 0.9%. And those over 10 years, they only showed a change of 0.5%. So if the program would be rewarded and actively offered immediately after diagnosis, effective improvements would result and subsequent damage would be prevented in a really early stage. Adjustment in the first year after diagnosis has a decisive influence on the complications rate. In the end, after finishing our study, we did some pharmacoeconomic research, and you can see in this slide for the pharmacoeconomic evaluation, the program costs for the program were included, which amounted for around about 450 euros per person for the intervention group. And to determine the cost effectiveness of the program, we had been using a net benefit health function. The results of the primary endpoint was included. And as you can see in this slide, for patients with an A1C level higher than study inclusion, cost effectiveness would depend on the patient's willingness to pay. So let's come to the conclusion. Concerning the endpoint A1C value, Glycemia 2.0 is one of few randomized controlled trials dealing with intensive diabetes care in community pharmacies. The study resulted in a significant reduction of the A1C values within one study year in comparison with the control group. This is a clinical relevant outcome. Concerning the weight reduction, 5%, we had positive therapeutic effects according to weight reduction and provided evidence with reduction of A1C. So to sum it up, preventive care by community pharmacists is really possible. And we can offer it as pharmacists in a structured way, participant-based and target-oriented. We have significant reduction of clinical endpoints participating in this program. So in the end, let's talk about future, and maybe this also leads to the discussion afterwards. What has still to be done in Germany and maybe also in Indonesia? We have absolutely to intensify and to push public relation activities. We should issue press releases, reports, interviews, printed and online, in the pharmaceutical press, but also in layman's terms like in diabetes guidebooks and diabetes journals. So in Bavaria, we also put all the material of our study on our homepage and try to motivate the pharmacists to use them. And we will soon publish online ahead the publication about the health economic evaluation of the study as an example of a complex intervention. Online ahead should be published now, and in December it will also be published in printed version. And of course, we will use these results for off-the-record conversation with health politicians, because we absolutely want to convince them that it's important to do something. And in this thing, we try to work for the future. We want to persuade that it must be our future as pharmacists. It needs health policies for the implementation of further pharmaceutical services driven by science that meets the practice. And we need more efforts to motivate community pharmacists to use the programs, or at least parts of the program, for their diabetes patients. That is to say, we need reimbursement programs to motivate and to provide the evaluated materials. And it's quite interesting. In 2 days, it's the World Diabetes Day. And look at this slide, what the International Diabetes Federation is saying. They say they have a call on policymakers to increase access to diabetes education for the people. And it asks for sufficient human and financial resources to be dedicated to diabetes education, to work towards the goals of the World Health Organization diabetes coverage target by 2030. So the IDF also said, please send letters to policymakers. This is a clear way to hold them accountable to their international commitments on diabetes. And they also, they created something like exemplary letters to use in order to send them to competent authorities or even to the politicians to support these goals. In the end of my presentation, just to show you that you can have an optical impression on the materials for our study participants. We had flyers, we had handbills for activity and screening weeks for type 2 diabetes. We had something like personal value leaflets, spreadsheets concerning sport, check-up lists, fact findings, and we also had certificacy for the participants who managed to have a lot of walking, that had a lot of steps counted by the P2 meters and so on, all to motivate the participants. We had prevention paths, we had these special lectures for the pharmacists, and in the next slides I only show you that you have an optical impression of the slides of the lectures for the participants. So taken from the first lecture, prevention instead of leaning back, stand together for an active and healthy future, and the pharmacist had to fill in his name, the profession, and the name of his or her pharmacy, and so it was to explain what can you expect today, type 2 diabetes, chronic disease, consequences, blood sugar, and so on. Also something about chronic diseases, adult onset diabetes, metabolic disease, everything around about the blood sugar, potatoes, ingestion, digestion, transport in blood circulation, and so on. These were all the slides. How does insulin work? What is the effect? Blood sugar and insulin levels, and so on. And the function of the blood sugar, of course. And the pharmacists, they were given also texts that they could work with, so that they didn't have to invent the speech itself. So now we come really to the end of my lecture. This is the publication in Diabetes Care. So if you are interested to read the publication, you can see it there. And in the end, I would really like to say a really big thank you to all the participating pharmacists, even if they cannot hear me this day, but it was really a big effort for them. They had to work very hard for the whole of the year, and we were very happy that they worked together with us to reach this success. Yes. And that's it. It's been really an honor and privilege. Thank you very much for your attention. Terima kasih.
Terima kasih, Dr. Helmut Schläger. So, yeah, you can have your seat back. So I'd like to sum up a little bit about Dr. Helmut presentation. So it's about how the pharmacy community can also contribute to the intensive diabetic care program and how that can improve the A1C level and also the weight loss of the participant in the intervention group. So for now, I'd like to invite the audience to ask one or two questions for Dr. Helmut. Yeah, please, Dr. Karen. Doesn't work. I have another mic here.
Thank you. That was a wonderful talk, and it was very interesting to see the impacts that you had in the period of the study. What would be even a greater impact is if those impacts continued beyond the study. From the surveys that you did, could you gauge whether these behavioural changes of the patients were continuing?
Well, the problem for a little institute like our institute is that unfortunately we do not have the financial resources and a lot of PhD students to go on further. Of course, you should work further and see how will it develop in the future. Some of our partners even, they said, well, could we go on and work on this study for several years? But this is something I have to explain. As I told you, this little institute is an institute of a chamber of pharmacists. Yeah. So our first interest is, of course, the science. But we do this for political reasons. This was the third study. We had a first study on coronary diseases, and we showed that the pharmacist providing preventive care could reduce the risk for heart diseases and so on. We had a second study, Glycemia 1, primary prevention, and this was the third study. And unfortunately, I have to say, this also was the last study. Why? Because, of course, science is the work of the universities. And really, this institute is a small institute, and our first aim was to show and to prove politicians and even the health insurance, pharmacists can do it better. You agree, right? And, of course, science is very important, and you can show it 3 times, you can show it 10 times, and you can show it 100 times. As for pharmaceutical care, We were working 30 years hard in Germany, all together, all the universities, departments of clinical pharmacies, and we have very often proven pharmaceutical care driven by the pharmacist is great. And finally, this year, in summer 22, we reached a goal. We have the first time reimbursed pharmaceutical care. A pharmacist in Germany, in a community pharmacy, which offers medication analysis for patients with at least 5 drugs. He will be paid now 90 euros. It's not too much, but it's okay for medication analysis. And of course, in preventive care, it's the same. Maybe you have to work for 20 years or something like this, but our aim was to show pharmacists can do it, and now it's the work of the politicians. But my true interest, and I hope that there will be more pharmacies, more universities that also do more research on preventive care, because it's...
Any more questions from the audience? Okay, maybe I would ask about the chemical analyzer, the one that is that provided in the community pharmacy?
The Abbott analyzer is unfortunately very expensive. It costs around about, I don't know exactly, in Germany, 3,000 to 5,000 euro. So community pharmacies usually don't have this device, only very specialized pharmacies. And so we had a cooperation with the company, and the pharmacists were given these devices for the duration of the study. They are, of course, very interested in introducing this in the market, and maybe one day when we have further improvements for these preventive care programs, then I'm sure some pharmacies will also buy these devices. What we do now, for political reasons, the study is finished and all the work is done, but as I told you, we want the pharmacists to use the material, and our president and his colleagues, they decided that from now on, if a pharmacist of a Bavarian community pharmacy will offer this program, he will get some kind of reimbursement. He will get money, at 100 euro per lecture, 100 euro, for example, if you offer screening for your patients and so on. And why do we do this? Because up to now, there is no money from the statutory health insurances. But we want to maintain our aim and our goal, and we want some pharmacies at least doing that. And we also, this is not a real scientific work, but this is what I said, you have to release press issue, you have to write something, yeah? And so we can say, look, we have some pharmacists in Bavaria, they offer this program, they get money by the Bavarian Chamber of Pharmacists, it's only little, but this is to continue to the work. And back to your question, I was already talking to the company, and of course, if a pharmacist does this the first time, he also has to look, is a good program, does it work in my community, does it work in my city or my village? So in the first step, he also won't buy this device for 3,000 to 5,000 euro, but he can also have it for maybe a month and pay a little fee, and then they can offer also these measurements again.
Okay, that's very interesting, because that's pretty handy, you know. So the patient just can come and we can measure all the levels that we need, the biomarkers, especially the A1C levels. So yeah, thank you very much for your presentation. It was so lovely. And also thank you for the interesting exercise today. I think we're all getting healthier after one lunch meal. Yeah, so thank you very much. So join me to have a big round of applause for Dr. Helmut Schlager. Thank you. I'll get back to MC.
I would like to invite Professor Dr. Marianti Amangau to give the certificate for our distinguished guest today, speaker. All right. You got a lot of fries.
Professor Marianti, we would like to ask you also to give certificate to our moderator for this session, Apoteker Yulia Yusri Jabir. Thank you, Apoteker Yulia, for moderating our noon session this day.
We will now step forward to the oral presentation session from researchers around the world with various research fields. There will be 5 rooms prepared for this session, each with different research fields.
So the committee had divided all the presenter into 5 different rooms. So consisting of 4 rooms for offline oral presentation and 1 room for online oral presentation. So the room is start from room A, B, C, D, and E. So for room A, B, and C is located on innovative room in the 2nd floor of this hotel. And then room D is located in this ballroom. After that, room E is located on the idea room beside this ballroom. So you may pay attention to the room, and then other participants may look on the oral presentation, but we would like to ask all the participants to first contact the committee that stand by on each room, because there's a limitation of number of participants that can join in each room. You may enjoy the oral presentation. Thank you.
For your information, this session will last until 5 p.m. and you might have coffee break session within the oral presentation session. We would like to ask you to join back here in the ballroom at 5 p.m. for the closing ceremony. Thank you very much.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ya, baik kami sampaikan bahwa sesi untuk oral presentasi khususnya untuk room D akan kita laksanakan di ballroom ini. Jadi kami dari panitia mengharapkan kepada perwakilan masing-masing presenter untuk bisa ke depan. Ada beberapa yang perlu kami komunikasikan. Diharapkan untuk maju ke depan. Terima kasih. Ya, jadi saya ulangi, mungkin perwakilan dari Dedi Ma'ruf, tim dari Dedi Ma'ruf, Amalia Herunisa, Yayu Mulyasari Evari, Nasrul Watan, Arnida, Ibu Yusnita Rifai, Idin Sahidin, dan Reski Nugraha untuk bisa maju ke depan dulu untuk. Terima kasih. Ya, baik, untuk sesi oral presentation-nya akan kita lanjutkan. Untuk itu, dengan hormat saya undang kepada Bapak Afandi sebagai moderator, saya persilakan untuk naik ke depan. Ya, baik. Untuk itu saya serahkan kepada Bapak Andi Afandi sebagai moderator. Terima kasih. Ya, ini kita punya. Ini rule-nya nanti. Ini daftar nama-namanya nanti. Kita baca baru saja. Yang presentasi itu yang garis bawah. Di atas sendiri. Ini diganti. Totalnya tetap sama sekali. Ini jadi online. Ini apa bisa yang presentasi itu udah dimaruk namanya. Oh iya.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everyone. Welcome to the oral presentation on the second Icopmes 2022. Today, we have 8 oral presenters who will be presenting the various different research of field. And I'm here to chairing this oral presentation session. Before we start, I will emphasize the role of this parallel session. First one, the time for the presentation will be limited strictly to 10 minutes. After the presentation, there will be 5 minutes for question and answer session. In each presentation, one of our team will act as a timekeeper, and he will show us a timer during the presentation. Our team is sitting over there, wearing a red jacket. Please be aware that there will be alarm to notify you at 2 minutes before the presentation is over. So at 8 minutes of presentation, there will be an alarm. So it means 2 minutes left for presentation. When we reach 10 minutes, we apologize, or I will stop the presentation and proceed to the Q&A part. I think everything is clear. We have 8 presenters, and we will start from Mr. Dedi Ma'ruf. I'd like to invite Mr. Dedi Ma'ruf to join with me here. Test.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. The first of all, I would like to say thank you very much for the time to present my study. Let me introduce myself. My name is Dedi Ma'ruf. I am student in Magister Pharmacy, Hasanuddin University. And the title of my study is Effect of Extraction Methods on the Yield and Total Phenolic Content of cocoa bean clone MCC02 from South Sulawesi, Indonesia. Next. Introduction. Indonesia is one of the producer of cocoa in the world with various clone. One of the superior clone in South Sulawesi, Indonesia is MCC02, Masamba cacao clone 02, and cocoa phenolic compound were known had antioxidant and antimicrobial activity. The purpose of this study was to determine the effect of the extraction method and the total yield and total polyphenol of the cocoa bean extract. MCC02 clone cocoa fruit were obtained from three districts, namely Masamba, Pinrang, and Bantaeng. Next. Method, the first, the dry non-fermented cocoa bean are removed from the seed cell, and then the fat is removed by the press method, and then the cocoa nibs were extraction by maceration, microwave acid extraction, and ultrasonic acid extraction. And then analyzed by using spectrophotometry UPPs, using Pauling cycle to produce total polyphenol optimal. Next. Result and discussion. Result yield of the extraction. Number one, extraction method maceration. With sample 50 gram yield. 15.29 plus minus 0.60%. Number two, microwave extraction method using microwave acid extraction. Yield 13.13 plus minus 0.28%. Number three, extraction method using ultrasonic acid, yield 12.77 plus minus 1.12%. Result of the total polyphenol content. Number one, maceration method use extraction method use maceration. Total polyphenol content 28.80 plus minus 4.53%. Number two, extraction method using microwave acid extraction. Total polyphenol content 31.89 plus minus 3.34%. Extraction method number three, ultrasonic acid extraction. Total polyphenol content 39.7 plus minus 4.41. Conclusion, this study conclude that the extraction of this cocoa bean produced the highest yield in the maceration method, and the highest total polyphenol content was found in the ultrasonic acid extraction method. That's all. Thank you very much.
Okay, thank you very much, Mr. Dedi Ma'ruf. Now we have several minutes for Q&A session. We invite the attendees to deliver a question. Anyone? Maybe I have one question. Can you explain why microwave-assisted extraction produce more polyphenol content? I mean, do you have any explanation why the ultrasonic assisted extraction produce more content, more polyphenol content?
Tahu kenapa misalnya dia lebih banyak polyphenol kontennya dibandingkan yang lain?
Yeah. Baik, I'm using Indonesian language. Kenapa pada ultrasonic metode pakai ultrasonic itu lebih banyak polyphenolnya? Karena ya disinilah kami mau melihat metode apa ya yang dimana metode-metode sebelumnya ada yang sudah konvensional seperti maserasi, reflux dan segala macam. Jadi kami ingin mencoba melihat metode yang baru lagi ya dalam hal ini metode microwave dan sonikasi. Tapi hasil yang dihasilkan oleh pada penelitian ini ternyata bahwa di dalam biji kakao itu terdapat yang paling optimal dibandingkan tiga metode ya yang paling tinggi adalah metode menggunakan sonikasi atau sonikator. Terima kasih.
Okay, thank you very much.
Okay.
Please join me to give a round of applause for Mr. Dedi Ma'ruf.
Yeah. Okay, yeah. Thank you very much.
Thank you.
Assalamualaikum warahmatullahi wabarakatuh.
For the second speaker, I'd like to invite Ms. Amalia Khairunisa to deliver the presentation entitled Determination of Sun Protection Factor and Total Tannin Ethyl Acetate Fraction of Sungkai Leaves. So you have 10 minutes to deliver your presentation, and right, time is yours.
PPT?
Excuse me? Seconds.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Thank you for moderator to give me a time. I wanna tell my presentation. Okay, I want to introduce myself. My name is Amalia Khairunisa and I am from Lambung Mangkurat University. I want explain my research entitled Determination of Sun Protection Factor (SPF) and the Total Tannin Ethyl Acetate Fraction of Sungkai Leaves, Peronema canescens. Okay, next slide. Okay, in terms of Peronema canescens, it is a plant that grows in the South Kalimantan, maybe in the several region. Contain phenolic compound like tannin, alkaloids, steroids, saponin, and the flavonoid that have potential as antioxidant. We know that phenolic compound has the ability to scavenge free radical used as a sunscreen. We know that Peronema canescens may be used in traditional medicine like treat fevers, stomach ache, and etc.
But the previous study about the peronema carnation will be done with Mevina in 2019 with ethanol extract. Peronema carnation jack has antioxidant activity with IC50 44.9 ppm. And the previous study done with the Fadilatur Rahma in 2020. Then the butanol fraction of peronema carnation leaves has the potential antioxidant and the anti-tyrosinase activity. Okay, next. Okay, we know the panel compound in the peronema carnation is flavonoid and the tannin. Tannin has the antioxidant activity too, so it can be used as a sunscreen. The extract ethanol and the butanol fraction of sungkai leaves has been tested. However, the ethyl acetate fraction of peronema carnation is not determined. So, the study to determine total tannin concentration and the sun protection factor, ethyl acetate fraction of sungkai leaves, peronema carnation, so it can be developed a natural sunscreen. Okay, next. The method that I use is dry leaves of peronema carnation, make a simplicia, and then the simplicia is maturation with ethanol 96% and become a crude extract. And the crude extract also is the next in the fractionated with N-hexane and ethyl acetate is increasing the polarity. But in my research, I use ethyl acetate fraction. Okay, next. The method of total tannin content start from preparation of catechin standard as a solution. We have a standard curve catechin, and the equation it be seen in the slide. I use 1000 ppm catechin as standard, and then the absorbed value were measured at 50,000. Operating time is 60 minutes. And we can equation like that. Next. The determination of tannin total sample is start from 500 milligram ethyl acetate fraction at 10 milliliter. And then we add 0.5 milliliter solution plus 3 milliliter vanillin 1% in this vortex. And then you can add 1.5 milliliter hydrochloric acid. And then the sample will measure the absorbed value will measure at 500 nanometer, operating time 60 minutes. Next. The result and discussion, we have the total tannin of ethyl acetate fraction of sungkai leaves. I have 3 sample absorbent, and the total tannin will be measured, you can see in the slide, 0.5 plus minus 0.15, equivalent with the catechin as a standard, and the RSD value is 2.7%. Next, the second parameter that I use is the determination of SPF value. With in vitro SPF assay, you can send a question to determine the SPF value like that. Okay, we can next to the slide. Okay, the determination SPF value, I have 5.7 ppm. The protection category is the medium. The study showed that the ethyl acetate fraction of sungkai leaves has the capacity as a UV filter with concentration 300 microgram per milliliter, and the SPF value was 5.7 plus minus 0.0 ppm. The category protection was medium. So I use the determination SPF with UVV spectrophotometry. The capacity of natural SPF plant act as a sunscreen is related to the phenolic compound that we know the Peronema canescens have metabolic secundary like flavonoid, tannin, and etc. Okay, next. It can be concluded that the research total tannin concentration or total tannin content in the ethyl acetate fraction of Peronema canescens leaves is 0.5 plus minus 0.1% week for week equivalent taken as a standard. The sunscreen activity of the ethyl acetate fraction of Peronema canescens leaves, which has medium protection with an SPF value of 5.7. So it can conclude that the Peronema canescens has to develop a natural sunscreen. I think it's enough. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Okay. Thank you, Ms. Amalia Khairunisa.
Okay.
We invite the attendees to deliver a question related. Okay. Microphone, please.
Okay, thank you for the opportunity. I would like to ask, maybe you have read
I'm
about
sorry,
the
I
mechanism
don't hear
of...
your voice not clear in here. Maybe you can not clear in here. I don't hear your voice.
Oh, okay.
Okay.
I would like to ask about tannin. Maybe you have ever read about what mechanism,
What? I'm
how
sorry?
tannin compound possess their ability to screen the sun light.
What the concentration?
The mechanism of to
tannin
be a
compound.
sunscreen.
The mechanism of tannin compound to absorb UV rays.
What the? What the?
The mechanism of
the
phenolic compound to absorb.
Okay, the mechanism of phenolic compound in the tannin. We know tannin is divided to categories: tannin tannin conjugated and the tannin condensated. The tannin have hydroxyl group, so it can react with vanillin and hydrochloric acid, make a complex structure. The method of Peronema canescens, the method of the determination of tannin with vanillin and hydrochloric acid, so become red. The color become a red, so it can we can measure the tannin content like that. I hope you can.
Thank
Okay,
you.
thank you.
Thank you very much. Please join me to give a round of applause to Ms. Amalia Khairunisa. Now we move to the third presenter, Ms. Yayu Mulsiani Evari. I invite you to join me on the stage. She will deliver her research about optimum extraction condition of mango parasite leaves, Macrosolen cochinensis. Ms. Yayu, time is yours.
Okay, thank you very much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First, I would like to thank for the opportunity given to me to present our basic research on so this research will talk about optimization of extraction condition of mango parasite leaves Macrosolan cosincinensis using response surface methodology. Our team consists of me, my name is Yayu Mulsiani Evari, and Profesor Gemini Alam dan Husnul Khotimah. Next. So why do we use Macrosolan cosincinensis? Let us call it MC for today. Mistletoe or MC is a hemiparasitic plant. Research about MC, research about parasitic plant have been shown that it might contain closely same composition of phytochemical constituent with the host. So if the host is mango, which may contain mangiferin and other flavonoids, so the parasite might contain those compounds also. But actually, the previous research has been found that Macrosolan contain terpenoid, which is thymol, and several flavonoids like rutin, quercitrin, quercetin, and so on. With the composition of phytochemical compound in it, it possesses a wide range of pharmacological activity like antioxidant, anti-diabetes, anti-cancer, and hypoglycemic activity. Besides that, Kumal and colleagues also found that the total flavonoid content of MC is about 24.9 quercetin equivalent, and phenolic about more than 30 milligram gallic acid equivalent per gram. That this extract possess DPPH inhibition with IC50 of 65.9 microgram per milliliter. Furthermore, we are conducting evaluation of flavonoid compound, and we are looking to know that what extraction condition will lead to give us the optimum amount of flavonoid from MC. Previously, research has been found that duration of extraction, type and pH of solvents, particle size, and extraction method have a significant influence to obtain the optimum amount of flavonoids. Next. For further, in this research, we use ultrasound-assisted extraction. Why? Because this one of an advanced method to extract phytoconstituents in the sample. Why? Because this method is just need a short time, about in minutes, yeah, 15 or 30 minutes, or maybe 1 hour. Compared to the old method like maceration, it needs about maybe 3 days for obtain the phytoconstituents from the Simplicia. Furthermore, this method is also need a small amount of solvents, so we can save a cost for the extraction method. And also, this ultrasound-assisted extraction also benefit because it the yield we obtain is more higher than the other method, the conventional method. And why do we want to optimize the extraction? Previously, the extraction method in the previously research proves that there is a different kind of parameters influence the amount of flavonoids. For example, the optimum condition of flavonoid extraction from Curcuma zedaria, they use reflux method using 90% ethanol as the solvent, and the temperature 75 degrees and 92 minutes extraction time to obtain the optimum amount of flavonoid. While Jafar and their team research found that maceration 45 degrees Celsius and agitation using 37 of ethanol for 90 minutes will give an optimum concentration of flavonoid and also phenolic and antioxidant compound from Clitoria ternate. Therefore, we know that the optimum condition to obtain flavonoid from plants is different between samples because the structure of flavonoid, the substituent of the flavonoid in the plant is different. It makes it, it resulted the different condition of extraction, so that we investigate what parameters will be resulted the highest content of flavonoid from MC. Next. Yes, the objective of this research is to find out the significant parameter which influence the amounts of extract yield and flavonoids from Macrosolan cosincinensis. Next.
2 minutes left.
This is the material and methodology we use. That is the leaf of Macrosolan. We powdered using blender and the Simplicia being filtered to obtain the same size of particles and then being weighed. Next. Next.
Next.
And then we extract using ultrasound assisted extraction using sonicator. And then filtered, concentrated using rotary evaporator, then we obtain the thick extract. Next. Now, the flavonoid content will measured using spectrophotometer UV-Vis. Yes, we know the standard method to measure the flavonoid content of an extract. We mix them with aluminum chloride and then natrium acetate to yield a complex of flavonoid and aluminum, which were pale yellow to yellow in color solution. Next. Statistically, all analysis was performed in duplicate. So this method will be done duplicate, and the flavonoid result were expressed as means plus minus SD. And in this research, we analyzed the significance of quadratic models.
I don't have time anymore. So probably we can move to the result.
Okay, this is the result.
Right.
Next.
Next.
Next. Jadi this is the sample code we use in RSM. We obtain 15 models and we'll done in duplicate. Next. This is the Pareto chart of standardized effect, and we obtained that ethanol concentration and solid liquid ratio give a significant effect of the result of yield.
Right.
Next.
Probably, sorry. Can you move to
this
the
is
conclusion, please?
Yes,
Move to the conclusion.
we can move to the conclusion. Okay, the conclusion of this result, we found that ultrasonic assisted extraction was effective, reasonable, and potential to increase the extract yield and flavonoid content of MC leaves. The second, the optimal condition was obtained by RSM for the ultrasonic assisted extraction of flavonoid content from MC leaves. We're using solid liquid ratio between 1 to 15 ratio to 1 to 30, and then using 65% to 85% ethanol concentration and more than 45 minutes extraction time. Additionally, the major finding of this research is that macrosolan co-sinensis can be one of good flavonoid resources. Thank you very much. Next.
Thank you.
Okay, thank you very much for the opportunity.
Thank you. Unfortunately, we don't have time anymore to explore more about your research. But please join me to give a round of applause to Ms. Yayu Mulsiani Efari. Yep. Thank you. Yeah? If you have any question, is there any question from the attendees or the audience? Yes, unfortunately, no. Nothing. Okay, thank you. Our fourth speaker is Nasrul Watan. I'd like to invite you to join with me here on the stage. He will deliver his research about antimicrobial and phytochemical screening of endophytic Rhizoctonia solani isolated from root of Seluang belum. Is it ready? So, to remind you that we have 10 minutes time of presentation, and 2 minutes before the end, we will give you an alarm. Then, after 10 minutes, I will stop the presentation. And we have 5 minutes for Q&A session. All right? Mr. Nasrul, time is yours.
Okay, thank you. Okay, Assalamualaikum warahmatullahi wabarakatuh. I want to say thank you for moderator that invite me to stand here. Let me introduce myself. My name is Nasrul Watan. I am from Lambung Mangkurat University, and in this opportunity, I will present my study that is antimicrobial and phytochemical screening of endophytic Rhizoctonia solani isolated from root of Seluang belum, Profunga sarmentosa bloom course. Okay, next. Our introduction, my sample. I use my sample is Seluang belum. Seluang belum. The Latin name is Leufunga sarmentosa. The roots and stems are using by the Dayak and Banjar tribes to increase stamina, male fertility, empirical to cure back pain, abdominal pain, and also increase sexual vitality. It's consumed in the form of pieces, chopped traditionally processed, like the in front of my presentation. Okay, next. This is the sample, the plant, and I explain the phytochemical content. The root, it was contain phenolic, flavonoid, and steroid. This is my previous study. And then from the leaves of Lufunga sarmentosa have substances terpenoids and flavonoids. There are several triterpenoids like apotyrocalen and tyrocalen, and then 2 types of coumarin and 5 triterpenes compounds like fridolin, flindisone, eleanon, dilotisine, and limonin. Okay, next. Okay, this is the area from the sample. This is from Tabalong district, yeah. It is located in Tabalong district, South Kalimantan. In my previous study, I have obtained 6 fungi isolated from Seloang Belum root, and this research I will study about Rhizoctonia solani endophytes. Okay, next. This is my methodology. I have endophyte Rhizoctonia solani, and then it incubated with shaker for 14 days, and then centrifuge to separate of biomass and supernatant. And then the biomass, it was cell that must lysis for metabolites. And then after lysis, we have to extraction with method microwave assisted extraction. After that, the extract, we will phytochemical screening and GCMS screening. The extract, we put antimicrobial test like antibacteria and antifungi. Next. Okay, this is my results of my study. This is microscopic analysis that was 100 times magnification. This is after freeze the cell biolysis, and then we check in the microscope. Next. Yeah, from the screening, phytochemical screening, we have identification the extract, and so that extract contain terpenoids and flavonoids, and then they have relativity with the host of endophyte. Okay, next. Yes, this is the chromatogram of GCMS of Rhizoctonia solani isolate. We have 2 metabolites that 80% like ethyl propionate and toluene. The other is lowest from 85% quality. And then from antimicrobial tests, there are inhibition zone diameters. We use extract sample, that was 3 replication, and using control positive for bacterial, S. aureus and E. coli, we use amoxicillin. And for antifungi, I use ketoconazole for Candida albicans. From the my study, we have results, diameters, that was 11.5 plus minus 2.559 for Staphylococcus aureus. And then E. coli, it was 3.37 plus minus 1.91. For Candida albicans, we have 11.28 plus minus 1.73. From control positive, it was still lower from control positive. Okay, next. So from phytochemical screening, we have results, the similarity of the secondary metabolites screening, that the endophyte produce have same produce metabolite is thought to have undergone co-evolution of genetic transfer between endophytic fungi and their hosts. Next, and GCMS analysis. There are just toluene that have 85%, and below 85% cannot be concluded to be same as compound in GCMS
2 minutes
library.
left.
Next. So my conclusion from this study, the results indicate that endophytic Rhizoctonia solani from root of Lufunga sarmentosa is potential source of antimicrobial agents. Like that.
Thank you very much. So we now move to the Q&A session. Is there any question from the audience? All right. No? Is there any question? All right, if there is no question from the audience, I'd like to thank you for your presentation.
Thank you.
Thank you.
Okay, Assalamualaikum warahmatullahi wabarakatuh.
Now, our fifth speaker is Arnida. We will be presenting her research on phytochemical constituents, flavonoid content, antioxidant activity of ethanolic extract of Spatholobus littoralis Hass stem originated from central Kalimantan. Yes. To remind you, you have 10 minutes presentation, and we will give you an alarm if we have 2 minutes left, and I will stop you after 10 minutes. Ms. Arnida, time is yours.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thanks to moderator for this time. I want to presentation my research. The title, phytochemical constituents, flavonoid content, and antioxidant activity of ethanolic extract of Spatholobus littoralis Hass stem originate from Central Kalimantan. Interaction, antioxidants are compounds that play a role in inhibition oxidation reaction caused by free radical. The compound having antioxidant potency are usually flavonoid, phenolic, and alkaloid. Kalimantan is one of the
slides, please.
Change. Ya, change. Change ke belakang. Bunita belakangan juga. Siap Ibu Bunita.
I do apologize because we have technical issues. We will call you back later, Miss Anida. Our next speaker, our next presenter is Mr. Idin Sahidin. I'd like to invite you to join with me on the stage to present your research, to deliver your presentation about your research. LC MSMS analysis of potential cytotoxic against breast cancer cell lines of ethyl acetate subfraction of soft coral Nephte sp. Time is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. The first, I would like to thank to the committee for the opportunity to me to present our research project. In a small research project with title LC-MS analysis of potential cytotoxic against breast cancer cell lines of ethyl acetate fraction of subcoral Nephte sp. I am Sahidin.
Next.
Back to the first slide. I'm Sahidin from Faculty of Pharmacy Universitas Haloleo. This is my colleague in this research. Yeah, next. Maybe some of you never visit to Kendari. Here Kendari, about 1 hour from Makassar using direct flight. And this is a moment when I exercise in diving, especially scuba diving, when I took the sample. Next. Sulawesi Tenggara province has 651 islands and about 20% is the sea. There are abundant marine natural resources of the province, one of which is soft coral. This is a photo of Nephte sp. This is a map of Southeast Sulawesi. And based on a literature review, searching in Science Direct and Springer Link, information study of chemical and pharmaceutical aspect of this genus is still limited. So, the purpose of this article is to present the result of a preliminary study on the chemical and pharmaceutical aspect of Neptea propraxen. Next. This is the general method. The first Neptea sp using ethyl acetate to get extract ethyl acetate. And from here, we use vacuum liquid chromatography to get fraction and to do one of the sample for continue, we selected by cytotoxic assay, MTT assay, using MCF7. So the potential fraction, we continue with phytochemical screening and LC-MS analysis, so we will get compound profile and biological activities. Next. This is the chromatogram of the fraction. This is fraction A, B, C, D, E, and F. This is this profile. This is the chromatogram. The next. Cytotoxic potency of the fraction, you can see in the picture. In here, fraction C is the most active, following by fraction A. So, to fraction, we continue with chemical analysis. Next. Based on a chemical profile, using a phytochemical screening, fraction A and C contains saponin, tannin, alkaloid, and terpenoid. Next. This is a LC-MS data. From here, from fraction A, the major component, we have identified 4 of 5 component. The number 1 is acetylene, second languager. This is the, in the bracket is a reference. Butyl anthracycline, one of the compound is unidentified. And from fraction C, there are 8 major component to have been identified. This compound, benzoferon and cephaloxypylenon B. From here you can see the unidentified, you can see here, 5 of 6 is alkaloid compound. Next. This is analysis of the fragmentation of the compound. So we can get conclusion, number 1, number 2, like this. This is the fragment. This is the MZ, the mass here, 247 is the most stable. The next fraction with breaker-breaker that. This is the compound 1, compound 2. Next. Compound 3, compound 4, yeah. Next. This is a fragment for fraction C. This is compound 1, compound 2, and now here this structure of identical compound from fraction C and fraction D. This is the structure. Most of them is monoterpene and diterpene. Next. Correlation of compound to cytotoxic activity. Fraction A and C of Neptea ethyl acetate extract had better cytotoxic potential gain breast cancer cell line MCF7 than other subfraction B, D, E, and F. Subfraction A is the moderately active category, while subfraction C is the active category. This is thought to be caused by the main content of secondary metabolite in subfraction C, which alkaloid. This molecular formula. This is relevant to breast cancer drug used by the patient, namely tamoxifen. Tamoxifen is one of the alkaloid. Okay. Next. As conclusion, fractionation of Neptea sp ethyl acetate extract produce 6 subfraction A to E. Subfraction C is the potential cytotoxic gain breast cancer, MCF7, line with active category. Based on LC-MS data, the major component contain subfraction alkaloid consists of, this is a molecular formula. So from here, we can continue to isolate this compound. So the possibility to get new compound is, I think, is bigger to get this new compound. The next, this is selective references. Next, I would like to thank to Kementerian Pendidikan, Kebudayaan, Riset, and Teknologi Republik Indonesia for supporting research funding via hibah penelitian dasar pendidikan tinggi in this year 2022. The next, this is my partner, this is my colleague. This is a moment when I took the sample, like here, using a scuba. I just waiting in the boat. Okay, next. Thank you very much.
Thank you very much. Is there any question to Mr. Sahidin? Right. May I ask you one question, sir?
Please.
Could you let us know how you develop or how you choose chromatographic condition and mass spectrometric condition? Because I couldn't see the chromatographic condition, and mass spectrometric condition. How do you choose or develop?
Okay. This chromatographic in laboratory, I don't have this chromatography. I joined with the LIPI,
okay,
Indonesian Science Institute.
Okay.
This is just to analyze the probability. What is the compound? Maybe prospective to do. For me, because I am a natural product chemist, I usually look for a new compound. So they are probable to get new compound. For the next, this is the beginning step. In the
so you collaborate with LIPI?
LIPI and ITB and University Kebangsaan Malaysia.
Okay. Thank you. If there is no question anymore, so please join me to give a round of applause to Mr. Sahidin. Thank you very much, sir.
This is Prof. Eli, Prof.
Prof. Latifah.
Terima kasih. They are my guru.
Yes.
Makasih. Assalamualaikum warahmatullahi wabarakatuh. Prof. Latifah. Prof. saat ini.
Thank you. Thank you, sir. Now we invite the next speaker, the next presenter, Ms. Reski Nugraha, to deliver presentation on ADMET properties prediction of piperine-based sulfonylamidine. Ms. Reski Nugraha, I would like to remind you that we have 10-minute presentation, and we will warn you after 8 minutes that we have only 2 minutes left, and I will stop you at 10 minutes presentation. Time is yours.
Oke, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, thank you for attending this presentation. It's an honor for me to present my paper in front of you all. Let me introduce myself. My name is Reski Nugraha. I'm a magister student from Department of Pharmacy, Universitas Hasanuddin Makassar. In this session, I will present my paper with the title Absorption, Distribution, Metabolism, Excretion, and Toxicity Properties Prediction of Piperine-based sulfonylamidine. In this paper, I'm the first author. The second author is Professor Dr. Sartini, MSc, APT, and the third author as corresponding is Mr. Muhammad Aswad, SSE, MSc, PhD, APT. Okay, the main idea of this research is start from the potency of piperine. We know that piperine is naturally alkaloid highest found in pepper plant or pepper nigrum. Piperine exhibit various therapeutic effect as antibacterial, antimutagenic, and intestinal enzyme stimulator. Furthermore, piperine can increase the effectiveness of drugs, vaccine, and nutrient by inhibiting various metabolic enzymes. Piperine can also act as immunomodulator and transporter modulator. Therefore, piperine is a potential candidate to be developed into a novel drug. Next. Nevertheless, the discovery of natural compound with pharmacological activity does not certainly increase the number of marketed new drugs. It's because the poor drug-like properties can limit exposure of the compound to the target protein and affect its toxicity. In the past few decades, 90% of clinical drugs have failed during clinical study, phase 1, 2, and 3. So, since piperine has low solubility, it is still limited use in market right now. Next. Okay, here the structure of piperine. Piperine consisting of methylene dioxyphenyl, alkyl chain, and thioamide. And thioamide consisting of heterocyclic ring. Modification of this structure to increase the solubility of piperine has conducted before. Modification at the amide group can cause a change in molecular energy and affect the solubility of piperine. Next. In 2018, Aswad et al. Has succeeded in designing modified compounds of sulfonyl amidine derivatives from piperine. Next, the sulfonyl amidine derivatives were designed by adding the sulfonyl amidine group at the amide position using the coupling reaction between the tone 10 contained methyl group. The addition of a sulfonyl amidine group at the piperine amide position increase the solubility and expect to improve the physiochemical properties of piperine. And one method that can be used to assess physiochemical for natural compound is in silico. In silico methods are the leading edge potential tools, reduce research time, anticipated loss due to failure experimental assay, reduce animal sacrifices, and then increase the chance of success in many stages of discovery process. Accordingly, to overcome the possibility of drug development failure in the future, it is necessary to predict the ADMET profile of piperine-based sulfonyl amidine compound. The results of this study are expected to show piperine-based sulfonyl amidine compound with the best ADMET profile prediction to proceed it in future research stage and will be able to develop into a new drug candidate. Next. Okay, let's move to experimental. As a computer-aided drug design, in this method we do a computational chemistry using in silico software. The molecule test is 12, consisting of piperine, thiopiperine, and 10 sulfonyl amidine derivatives mentioned in the previous slide. So first, the three-dimensional structure sketch used a Mervin sketch, and the structure was converted to the SMILES format. For your information, SMILE is chemical notation to encode the structure into the text. Then, the SMILE code is then entered on the in silico software and web server. In this method, we use one software named Tox3. You can see the main page on the slide. Tox3 is an open source application to predict the toxicity hazard. Besides, we use 4 web server. First, ADMET Lab, and second is Swiss ADME from Swiss Institute of Bioinformatics. Smart CYP by Lars Olsen et al. And PKCSM from Biostic Lab, University of Melbourne. Okay, this is the result and discussion. First, we assess drug likeness evaluation from Icopmes Lab. This server determining drug likeness compound by several rules, include Lipinski, Gauss, Faber, Egan, and Much. You can see the content of the rules in the next paragraph. Next. Okay, it's a drug likeness evaluation from Swiss Icopmes. Next. So, based on the data from Swiss Icopmes,
2 minutes left.
all sulfonylamidine derivatives are predictorily bioavailable, except for compound 3, 8, and 9. According to data from Icopmes Lab, compound 10 fulfills the requirements of all parameters. This result influenced by 3 biochemical properties. First, molecular weight, and then the partition of coefficient log P, and the topological polar surface area or TPSA. Molecular weight can affect the solubility of piperine because the large molecular size needs more cavity in water in order to solubilize the compound. The large molecule size also obstructs passive diffusion and reduce the compound concentration at the surface of the intestinal epithelium, thus reducing the absorption. And then log P measures how hydrophilic or hydrophobic a chemical substance is. Increasing log P decreases aqueous solubility, which reduces absorption. Instead, reducing log P increases solubility and lead to higher systemic exposure. And TPSI is the total hydrogen bond count. Very high values of TPSA result in poor drug absorption. The addition of sulfonylamidine group to the amide position of piperine causes increase of molecular weight, log P, and TPSA, thus decrease the solubility of all piperine based sulfonylamidine.
Time is up, so probably we can jump to the conclusion. We can jump to the conclusion.
Okay. Okay. So based on the result and discussion, we can conclude that prediction of drug likeness, Icopmes, and toxicity of piperine, thiopiperine, and piperine-based sulfonylamidine showed varying results. Compound with diphenyl, nitrobenzene, 3-fluoromethylbenzene, and 1,3-bis-3-fluoromethylbenzene substituent have the lowest values of biochemical parameter, Icopmes, and toxicity, whereas compound with methyl substituent has the highest score of all parameters. Therefore, this compound promising good Icopmes properties to be developed into a novel drug. Okay, that's all that my presentation.
Thank you very much. Now we invite you to give a question to our presenter. Is there any question? Okay. At the back, please.
Thank you for the time. My name is Muhammad Toha. I'm a student of Master Pharmacy of Unhas. My question is, does in silico score correlated with the in vivo and in vitro test? Can you give me any example? Thank you.
All right. I think it. Yes.
Okay, thank you for the question. So first, I want to make clear to all of us that in silico resulting a prediction. So the score mentioned in the table before is not a real value to in vitro or in vivo test. Can we back to the slide?
Slides, please.
Okay, all I can say that in silico is just a prediction, but the prediction is necessary for the drug development because this prediction can be consideration to continue the development of the drug into the in vivo or in vitro test. That's all that I can say. I hope it's complete your question. Thank you very much.
All right, thank you. Now we move to the next presenter. I kindly invite Dr. Yusnita Rifai to present her research about docking and synthesis of favipiravir derivatives using microwave irradiation methods. Dr. Yusnita, I would like to remind you that we have 10 minutes presentation. Yes. Yeah.
Slide, please. Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Yeah, today I would like to talk about docking and synthesis of favipiravir derivative using microwave irradiation method. Please let me take a seat because I don't feel well today actually, so I need to take a seat. Favipiravir is one of the alternative treatment for COVID-19. It is actually using for drug repurposing because actually in COVID-19 we didn't find any exact drug to treat the COVID-19 since 2019. The mechanism of action of favipiravir is actually act as RNA-dependent RNA polymerase inhibitor. And it is actually directly can inhibit RDRP, so it can also maybe inhibiting SARS-CoV-2 RDRP. However, it has weaknesses, less affinity between favipiravir active with protein enzyme RDRP SARS-CoV-2. So it has EUA in Japan, in the US and Indonesia. So from Food Drug Administration of the USA, it has emergency use utilization authorization from Food Drug Administration. In 2021, RABI has found that drug candidate of COVID-19 treatment with better stability by modifying amine structure of favipiravir. So in our study, we use another methodology to synthesize the derivative of the favipiravir using microwave irradiation. We choose this methodology because microwave irradiation is more effective and efficient in doing warming process during synthesis process. This is the methodology. So first of all, we weigh favipiravir with 2-nitrobenzaldehyde and we co-solve with ethanol and added with acetic glacial and then heat it up and then put it at microwave for 90 seconds and then we do crystallization and then we recrystallize with ethanol and then dried it up and then wash it with water, ethanol and hexane until we obtain the powder. For the characterization, we use some of instruments, for example, TLC, melting point apparatus, spectrophotometer UV-Vis, molecular docking, nuclear magnetic resonance spectrophotometer, infrared and mass spectrum. Now we come to the results. So this is the proposed mechanism reaction. So favipiravir will be added with nitrobenzaldehyde, and then we add acetic glacial to find to actually substitute hydrogen from favipiravir and then substitute it with alkene. So it's going to combine the nitrobenzaldehyde with favipiravir. Next, please. So now we come to the results. If we compare between favipiravir and the derivative, by organoleptic, by seeing the organoleptic, favipiravir derivat shows specific smell and then light yellow powder, and it's solved in water, methanol, and ethanol. And the melting, it has a slower or lower melting point compared to favipiravir. So this is the result of UVP spectrophotometer. Next, please. This is the result for infrared spectrophotometer. So also we can see here that some of the functional group peak we can find from the picture. Next one. Also for the derivative, we can see that we can display the alkene which combine between favipiravir with benzaldehyde. Next, please. This is the NMR result, and then carbon NMR result. Slide, please. Next. Make it quick. And then we can see the mass spectrophotometer, and then we have calculated all the molecular weight, and when we go around 471 for the base peak. And in terms of in silico result and lipopolicity level assay, we got some comparison here. So you can see that VPV derivative has log P better than favipiravir itself. By seeing the in silico, this is the native ligand picture. Next slide. And then we compare to FPV RTV, which is native ligand of the experimental, and then next. So we can find out that actually by seeing the result of this experiment, we have found that by computational FVP or favipiravir derivative can inhibit RDRP enzyme coronavirus by having scoring minus 9.5 with the higher lipopacity level of 0.72 compared to favipiravir. I think that's all. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. It's okay. Thank you, Dr. Yusnita. Now we move to the next presenter, Dery Setiawan. We kindly invite you to on the stage. So I'd like to remind you that we have 10-minute presentation, and afterward we'll have discussion as well. Time is yours, sir.
Okay, thank you very much for the time. My name is Denis Setiawan. I will present our presentation. This is the title of our presentation today: Phytochemical Screening and Antioxidant Activity Ethanol Extract of Tandui, or Mangifera rufocostata coston. Okay, Mangifera rufocostata coston is one of the Anacardiaceae. We call always mango in Indonesia, but the family was have some phytochemical screening, but Tandui will we will explain in this presentation because little of
Please
okay,
wait.
Sorry.
Slides, please. We apologize for technical issue. Our team is working now. I think we can restart the timer. All right.
Okay, thank you. This is the Mangifera robustata, the family of Anacardiaceae. We often use for diabetic and stroke, and it related to antioxidant activity. We know the antioxidant is more potent to prevent some medical problem. Yeah, the part often used was fruit leaf and bark. This is the leaf we will explain here. Okay, next please. This is the method of our research. The sample was taken from South Kalimantan and determined in Kebun Banua, South Kalimantan. Extraction was measured by ethanol in 6 days, and screening phytochemical compound was alkaloid, saponin, phenol, flavonoid, tannin, steroid, and terpenoid. And antioxidant activity identified by qualitative and quantitative method. Okay, next. This is the result of identification, phytochemical identification. We know that tandui leaf have some compound, tannin, phenol, flavonoid, and saponin. Okay, next. This is the result of KLT or TLC. We use N-hexane and ethyl acetate 5x5. And we use 3 analyze that RF value was have 5 and 4 spot that higher in point B. Okay, next. We use N-hexane and ethyl acetate 3/7. We analyze that component spot was in 4 spot that in B and C. Yes. Okay, next. This is N-hexane and ethyl acetate 2 and 8, 2/8. Have 4 and 3 spot. Okay, next. And this is the result of qualitative analysis. We use quercetin to compare the component of antioxidant. We have IC50 of quercetin was in 3.3 and IC50 probit in 2.9. Okay. Next, this is the result of the sample that we have calculate the IC50 in 7 by 6 and IC probit in 6 ppm. This is the conclusion of our research that tandoori have some phytochemical compound we call tannin, flavonoid, phenol, and saponin. From the qualitative analysis, we know that tandoori have some antioxidant activity, and for quantitative analysis, we saw that tandoori have some strong antioxidant activity in 7 by 6 ppm. Okay, this is we know we thanks to Center of Study and Natural Ingredient based OLM and Laboratorium of Pharmacy. Okay, maybe this from.
Thank you very much, Mr. Dari Setiawan. I think we have time for Q&A session. Is there any question from the audience? Okay. Oh.
Yeah. Thank you for the great presentation. So I just want to ask about the future expectation about this research. So is there any possibility that we can develop this leaf, this compound, into making it into a certain pharmaceutical ingredient and make it as and test in the in vivo study? That's all my question. Thank you.
Okay. This is the first what activity with the we have get, yeah. The next we will find some activity, maybe like antibacterial activity. This is the maybe an antifungal activity. We will research that for the next research, maybe.
Thank you very much. Please join me to give a round of applause to Mr. Dari Setiawan. Now, finally, we invite Ms. Arnida back to the stage to present about phytochemical constitution, flavonoid content, and antioxidant activity of ethanolic extract of Spatholobus littoralis stem originated from Central Kalimantan. Is the slides ready? Okay. Screen laptopnya putar ke sini biar dia. Screen laptop timernya putar ke sini biar dia.
Oke. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thanks to moderator for this time. I want to presentation my research. The title is Phytochemical Constituent, Flavonoid Content, and Antioxidant Activity of Ethanolic Extract of Spatholobus littoralis Hass stem originated from Central Kalimantan. I am Arnida and team of this research, Marlisa Puspandari, Sutomo, and Destria Indasari. We are from program studi Farmasi, Fakulti MIPA, Lambung Mangkurat University. Introduction. Antioxidants are compounds that play a role in inhibition, oxidation reactions caused by free radical. The compound having antioxidant potency are usually flavonoid, phenolic, and alkaloid. Kalimantan is one of the island famous of its biodiversity, the knowledge of traditional medication using plant were inherited orally passed generation to generation in central Kalimantan ethnic. One of those plants utilized empirically by Palangkaraya Society of Bacaka Tampala or Spatolobus littoralis has to agent cancer, diarrhea, dysentery, muscle sore, and hair on. Flavonoid is one of polyphenol compound, extractive antioxidant, antimicrobial, anti-allergy, antiviral, anti-inflammatory, and vasodilator nature. Flavonoid determination in plant called employed colorimetry method. This method involves aluminum chloride of principle on color change in complex formation. Based on previous description, research were interested to carry out phytochemical screening, flavonoid content determination, and antioxidant activity of Spatolobus littoralis stem ethanolic extract. The research was designed to provide information of phytochemical constituent found in ethanolic extract of Spatolobus littoralis stem, potential natural antioxidant, and could be used as scientific reference in future research. Research method, sample Spatolobus littoralis was collected from Palangkaraya, Central Kalimantan. The stem of Spatolobus littoralis were sorted, washed, and cooked. As much as 2 kg of simplicium powder were macerated using ethanol 96%. Phytochemical screening is one of the methods used to identify compound in plants. The screening was performed to Spatolobus littoralis stem powder and ethanolic extract by tube test and GCMS method. Total flavonoid content and antioxidant activity determination of Spatolobus littoralis stem ethanolic extract by DPPH method, and then data analysis. Result and discussion. The result of the identification of phytochemical contents of Spatolobus littoralis stem powder is flavonoid, tannin, and saponin. And the result of the identification of phytochemical contents of Spatolobus littoralis stem ethanolic extract was flavonoid, tannin, and saponin. The result of the identification of compound contents of Spatolobus littoralis stem ethanolic extract by GCMS of the chromatogram of chemical compound in cantilevers on using gas chromatography, mass spectroscopy originating from Central Kalimantan, seen in figure 1. The result of chromatogram of chemical compound of littoralis stem ethanol extract have certified peaks, but the compound that contain domain can be seen in table 2. Squalene chemical compound was squalene resorcinol, batulinaldehyde, hexadecanol acid, methyl ester. Based on the result of the GCMS analysis of the chemical compound of the ethanol extract of Spatholobus littoralis stem, were squalene, resorcinol, batulinaldehyde, and hexadecanoic acid, methyl ester. This table of the result determination of total flavonoid content was 842.84, and antioxidant and the result of antioxidant activity. The result of IC50 value of quercetin is 2.85, and this table of the result antioxidant activity of Spatholobus littoralis stem ethanol extract by the PPH method, and IC50 was 7.89. And then conclusion, the result of the identification of the chemical contents of the powder and ethanol extract of the stem of Spatholobus littoralis contain flavonoid, saponin, and tannin compounds. Conclusion 2. Second conclusion, identification by GCMS showed the dominant chemical compound were squalene, resorcinol, batulinaldehyde, and hexadecanoic acid, methyl ester. And then the total flavonoid content contained in the ethanol extract of the stem 30.39 equivalent to quercetin, and then based on the IC50 value of the extract ethanol, IC50 was 7.39, and this is indication of antioxidant activity in the very active category. Yeah, thank you very much. I think enough my presentation.
Thank you very much. Please give a round of applause to Ms. Anida. Do you have any question from the audience? Okay, I think that's all. Thank you very much. Finally, we've done all the presenters today. I am, as the chair of this session, would like to thank you for all of you for your attention, and we'll see you on the closing ceremony. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Ya, baik. Terima kasih banyak Bapak Andi Afandi yang telah memandu jalannya oral presentation kita pada sore hari ini. Selanjutnya kami persilakan kepada semua peserta untuk melakukan atau yang mau sholat bisa sholat dulu, Selanjutnya acara berikutnya adalah closing ceremony oleh panitia. Sekian dari kami. Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, we will now start our closing ceremony. For all participants, invited speaker and presenter, you may take your seat.
So, this is the moment that we have been waiting for, especially for the oral and poster presenter. It's time to announce the best oral and poster presenter. Let's all give the loudest applause.
It's been a tight competition for all the educator. Either it's best oral, or poster presenter. So we will start to announce the winner, starting from best presenter and oral poster. For best poster presenter goes to Apoteker Yulia Yusrini Jabir. Apoteker Yulia Yusrini Jabir come to the stage, and also we would like to invite the chairman of organizing committee.
We'll continue to our next winner. For oral presentation in room A, the best oral presenter for room A goes to Dr. Maan Aryadi Arsya.
Okay, we will continue for the room C oral presentation. So the best presenter on room C goes to room B. I'm sorry, my mistake. So for room B, the best oral presenter goes to Apoteker Rina Agustina, PhD.
presentation on the room C goes to Anugrah Yaumil. I repeat, if maybe the representation of her team can go to the stage.
I think the winner is not in the venue right now, so maybe we can skip it to the room D first, and then at the end we will invite Anugrah Yaumil back to the stage. So let's continue the announcement on winner. For best oral presenter on room, oh, the winner has come to the ballroom.
Let's give her applause.
So the best oral presentant on room D goes to
for the last room, room E. For the best oral presenter in room E1 goes to Andi Arjuna.
So we will continue to best oral presenter on room E2. Invited speakers, lecturer, and all the organizing committee and also all the participants to join the stage, and we will take a photo group together.
Okay, so we invite all the invited speakers, all the lecturer and all the committee and also all the participants to join us in the stage so we can take photo group together. I repeat, maybe all the participants and also all the invited speakers, the lecturer can join us in the main stage so we can take photo group together. And also all the committee. Semua peserta dan juga semua invited speaker serta dosen dan panitia bisa segera maju ke panggung utama untuk mengambil foto group bersama. Ayo, kepada semua teman-teman partisipan bisa maju ke depan untuk mengambil foto grup bersama. Yang di sebelah kiri bisa maju ke depan. Panitia juga bisa maju ke depan untuk mengambil foto grup bersama. Dia fotografer.
Semua peserta bisa naik ke panggung. Kita akan melakukan foto sesi.
Saya panggil dulu orang. Kepada teman-teman yang ada di sudut sebelah kanan, bisa maju juga ke panggung utama untuk mengambil foto grup bersama. Sekali lagi disampaikan kepada teman-teman, partisipan, serta panitia, bisa maju ke depan untuk mengambil foto grup bersama.
Cek. Iya, tapi ada yang berlutut sebagian, ada yang duduk, yang cowok atau cewek boleh juga, ada yang duduk di sini. Masuk di tengah.
Yang masih ada di meja dan kursinya mungkin bisa bergabung segera. Kita foto.
Iya,
mungkin panitia
duduk, iya.
yang masih ada di luar bisa
rapat Ki,
bergabung.
Ibu tabe masuk Ki. Waduh. Iya. Yang di depan itu ya duduk, boleh. Duduk. Wih, udah muat. Gimana ini? Di bawah sini. Boleh dibawa di sini juga kalau mau. Di depan ke sini, di bawah panggung di sini bisa. Adik-adik bisa isi di depan sini. Isi Maki di depan. Masuk semua ke tengah. Baik, tambah banyak. Tidak kelihatan Ki di situ, ada meja. Masuk Ki di tengah. Yang di sini juga. Oh, Male. Oh, Saso. Ya. Hantam lurus saja. Oke, Bim. Oke, lihat kamera Maki semua. Lihat kamera. Bim. Oke, lihat kamera, standby. 1, 2, 3. Lagi. 1, 2, 3. Bebas. 1, 2, 3. Hikmat. 1, 2, 3. Lebih bebas. 1, 2, 3. Paling heboh semua. 1, 2, 3. Terakhir. Heboh sekali ya. 1, 2, 3. Teriak A. 1, 2, 3. Bilang keju. 1, 2, 3 keju. Oke. Oke, cukup. Andi Cieng.
Nanti Vika. Tidak geser-geser kok, terlalu di sini kok. Ini kok. Congratulations to everyone who won the prize today. But we do really appreciate all the participants and presenter hard work during this conference. So, ladies and gentlemen, finally, we have now come to the end of our conference. It has been an honor to us to be host during these past 2 days.
We would like to take this moment to thank all of our moderators and invited speakers from Germany, Malaysia, Japan, and Pakistan, and also Indonesia, who made this session run smoothly. Please also give a round of applause to all the committee members for their work.
We hope you all enjoy yourself and walk away with full of new knowledge. We thank all of you for attending this conference and for being such an engaging audience.
We hope to